Test and stream. 1, 2, 3. Test and stream. 1, 2, 3.
Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test, test, 1, 2, 3. Test, 1, 2, 3. Test, 1, 2, 3.
Okay, thank you. Uh, I would like today call the virtual Board of Managers meeting 10 a.m. Thursday, December 10th. This meeting of the Board of Managers of Tarrant County Hospital District is now called to order, and welcome to all of you who are participating. I'm pleased to say that we are able to meet by means of electronic participation, thanks to the emergency orders of Governor Greg Abbott and Attorney General Ken Paxton, dated the 16th day of March 2020, which have temporarily suspended certain requirements and provisions of the Texas Open Meeting Act. Though we are not all able to physically meet at the boardroom, most board members are participating today by video conference using the WebEx web conferencing application. I'm asking all of us, board members, JPS staff, and general counsel, to be patient and do our best to make this meeting as smooth and effective as can be. And now I've got to do the roll call for the folks that are here who are participating. And let me get my little summary. All right, Dorothy.
Present.
Roger Fisher. Roger's not it. Charlie Powell.
I just got on, Dr. Weber, sorry.
Okay, that's okay. Gotcha. Amanda Arizola.
Present.
Ralph could not be here today. He had another obligation. DT Wynn. He's still working on his whatever electronics. Did I hear him? Steve Montgomery.
Here.
I'm here. Trent Petty. Steve, I talked about, and Zim Zimmerman.
Here.
Okay, DT, were you able to? I don't hear DT. Well, Leanne, if we would, can we proceed with the opening prayer, please?
Yes, thank you. So happy to be with you all today. I hear a little echo. Can you hear me okay?
Getting feedback like crazy.
Yeah. I don't know.
Yeah, if it can.
You sound good even with an echo.
Yeah, if David can mute people, I think that would help. So maybe if everybody will mute,
Leanne,
that would probably help.
Okay, let's try again. Is that better? I'm saying it was the Holy Spirit. That's what was happening there. I want to share with you what happened yesterday. Yesterday, a physician called me. This is a physician who's been on the front lines since March, and he just came back to work after having had COVID himself. He said he was physically exhausted and he has so many patients to see. But he said, I want to share with you this blessing. And the blessing that he shared with me really stood out to him because there's a word in this blessing that says, may your work never weary you. He said that is the perfect blessing for JPS because he said, though I've been working, 15-hour days since March, though I have COVID, though I still have COVID fatigue, he said, my work does not weary me because I work with such amazing people and everybody is so committed to this mission, to our patients, to our families, and we are all in this together. And I was so moved by that. And so I want to share with you today this blessing. And I would like each of you to take in this blessing for the important and crucial work that each one of you is doing that only you can do. So this, by John O'Donohue, blessing of your work. May the light of your soul guide you. May the light of your soul bless the work you do with the secret love and warmth of your heart. May you see in what you do the beauty of your own soul. May the sacredness of your work bring healing, light, and renewal to those who work with you and to those who see and receive your work. May your work never weary you. May it release within you wellsprings of refreshment, inspiration, and excitement. May you be present in what you do. May the day never burden you. May dawn find you awake and alert, approaching your new day with dreams, possibilities, and promises. May evening find you gracious and fulfilled. May you go into the night blessed, sheltered, and protected. May your soul calm, console, and renew you. May each one of you be blessed and know the holy and crucial work that you are doing. Amen.
Amen. If we would, we'd go to the Pledge of Allegiance, if we would. Everybody see it? I pledge allegiance to the flag
of the United States of America and to the republic
for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Any citizens wishing to address the board, Suzanne?
No citizens.
No citizens. Item 4 is the approval of minutes. Board of Managers meeting November 12th, 2020. I'd entertain a motion to approve and a second.
Mr. Chairman, I move for approval. Charlie.
Charlie.
Second.
Second by Dorothy DeBoe. Discussion. All in favor, please say aye.
Aye.
Aye. Those opposed say no. Motion passes. Item 5 is the board chair report. And my report is much the same as it's been for the past 11 months, which is thank you for all the people that are involved in taking care of unfortunate folks that are either in the hospital or at home. And we couldn't do anything without them. So I would say thank you. Robert will cover some of the stuff that I normally would, which is newspaper type stuff, COVID. And with that, since the majority of this meeting is related to financial matters, I've asked Steve Montgomery to go ahead and chair the rest of the meeting. And it's all yours.
Thank you, Mr. Chairman.
Next would be Robert, I guess.
Yes. So item 6 is the CEO report. Mr. Early.
Thank you, Mr. Montgomery. Thank you, Dr. Weber. I appreciate it very much. Let me give you all a quick update on where we are from a patient standpoint. We are now beginning to see a bit of the Thanksgiving increase. The increase we thought we would get a couple of days ago is now at least starting to muster itself in our process. We have 92 positive COVID patients in our facility today. That's challenging. We've had 3 additional deaths over the past 24 hours. That's unfortunately sobering. We have continued to see, like anyone else, the numbers of our employees that are becoming affected by COVID, both at their family level, with their children, spouses, neighbors, and that affects us. We still don't see a whole lot of the tracing of those people. We do not have a sophisticated tracing process, but we don't see the derivative or the origin of that COVID to be within inside the walls of the hospital as much as we see it coming from outside in the community. So those are our challenges today. We are certainly in good stead with our protective equipment. We still have plenty of ventilators. But as you can imagine, it is getting challenging, and that becomes a real concern. I had my meeting last night with the area CEOs. What THR is facing and what Baylor is facing is an increased number of people who are boarding in their emergency rooms. Baylor is really challenged this week with the number that is in their emergency room in holds. And that's going to be the same situation that we're facing. We had a tougher week last week than we're having this week with our holds, but it's still a constant challenge. No one wants to go and change policies. I talked to the folks at Baylor last night, and there's no reason for Baylor or anybody else to go on divert because there's nowhere to go with those patients. So we're all trying to help each other. THR is also stretched, beginning to be, and when I say THR, I'm talking specifically about their downtown Harris unit. They too have a boarding challenge, and they have additional patients coming in. What we're finding out, even though our numbers are higher today, the COVID patients are a challenge, but it's everybody that happens to be coming into our area emergency rooms right now. And as I talked to the CEO at Baylor last night, there's not a rhyme or reason to it. Those numbers are just increasing. So we definitely find that challenging. I will compliment the internal team here at JPS, and I will compliment the state for helping us with vaccines. We are now in a proper place to get our vaccines. We have communicated this morning and last night with Pfizer. Just to remind you all, the Pfizer allotment that will be coming in will be the first wave, and we'll deal with that. Pfizer, that vaccine has a little bit extra that goes with it in that you have to have cold storage, minus 80 degrees Fahrenheit for that. So we have plenty of storage capability to deal with everything that will be coming to us now and in the future. If we ever do get into challenges, we have a great relationship with storage capabilities at the county, which they have additional storage space for us to use. So we are grateful for the relationship that we have with the county. I will say that over the weekend, there was a lot of work that was done with the state, and the state officials really were helpful. This is their first time to do an allotment of a vaccine like this in a pandemic, and they too had their struggles in trying to figure out how to do this. So all hospitals are coping, and all my safety net colleagues in all the major urban areas of Texas are struggling with this to make sure that we get this right. The thing that was the most impressive, and I did have a conversation with Chuck and Dorothy and Roger, because you can't have one meeting for one purpose and not talk about other things. So we quickly went into vaccines, and our team, starting probably 3 weeks ago, and now culminating, has done an incredible plan for the distribution of those vaccines. And they have prioritized those that are the most likely to see COVID patients, where you're going to be with COVID exposure. And they have put together an incredible plan. As I mentioned, Pfizer has some nuances, not only the cold storage nature of it, but the Pfizer vaccine is a 2-time vaccine. So we will be monitoring those individuals for compliance. We are going to make it a voluntary process. I don't know of any other healthcare facility in the nation, certainly locally, that's making it mandatory. We did a quick survey and found that we probably have about 60% of those eligible for the vaccine willing to take the vaccine. And we will monitor that closely and work with our employees to make sure that they're confident and feel good about taking the vaccine. When the Moderna vaccine comes in, which will probably be in about 2 to 2.5 weeks after the Pfizer vaccine, that's a one-time vaccine. And we have already been notified by the state that we are in line for that vaccine as well. So I think JPS is in good shape. I think we're protecting our employees, and our policies and procedures for dealing with that vaccine are very, very in line with all the other health networks that we have reviewed, particularly the ones that are local. So the vaccine is certainly going well. Mr. Chair, or I'm happy to entertain on the vaccine any questions, and if there are not questions on that, then I'll go into sort of year-end comments. But Steve, I'm happy to answer any questions that members might have regarding the vaccine, or regarding where we are with COVID, or where we are with protective gear, ventilators, any of those questions.
and you can call me Mini Chair.
Okay. I'll call you. I want to make sure I have the proper protocol. And I turned to Daphne, and she was suggesting mini chair would be the proper term for you.
Mini Chair. So I did actually have a question for Robert. I don't know if you have data on this from our facility or from your peers, but in our ER, are we seeing a lot of patients from surrounding counties that don't have the medical infrastructure that we do coming here with COVID?
Mini chair, I'll give you a mini answer. No, that's not the case. We are not seeing anything that is abnormal or out of the ordinary. We're just seeing increases. And I talked to Harris, and I talked to Baylor All Saints, and I talked to Medical City. They're in the same exact situation. There isn't, the increase is coming from outside counties, or the increase is coming because of flu, or it's coming because of traumas. There is no rhyme or reason. It's just an increase, and it's that increase for all of us. Good question.
Got it.
Any other questions y'all have?
Robert, I have a question about visitors and what are restrictions with visitors that are coming into JPS?
I'm going to refer to Karen real quickly, because I'm pretty sure that we are still seeing one visitor.
Yeah.
We're still at that level where we have one visitor. We haven't changed that policy. We try hard not to. Now, we did, and Amanda, you and I spoke, when there was a lot of media coverage about changing elective surgeries and changing visitation and doing a variety of things differently. A lot of that came out on Thursday, and I have great respect, obviously, for those in the media that want to communicate to our citizenry. But for all of us, Thursday or Friday is a really difficult time to change any policies, because over the weekends, people obviously are going to have more time. They're going to be able to see people. So our policy for one visitor did not change, and we did not change that on Monday or Tuesday or Wednesday. We are going to look really closely and monitor that. That, Amanda, as you can guess, is the decision that no one likes. If we have one visitor, people want all visitation. If we stop all visitation because of COVID increases, there is a real frustration that people can't see their loved ones. So that's probably one of our most difficult situations, that whatever decision we make really concerns people. And again, if you want to see a loved one in the hospital, that's tough. So we've tried really hard to be safe with COVID, to make sure that people are protected. The one thing, and if anybody is listening through streaming, I would ask, and that is, if you are a visitor here, the masking rules apply to you. And it's not, we don't do part-time masks at JPS. And what I mean by part-time mask, it's not a mask that you put on when you enter JPS. It's a mask you keep on wherever you go in JPS, and that has been a real challenge. I will tell you, we got a potential patient yesterday who thought people at JPS weren't wearing masks. We are incredibly strict about mask wearing, and we've got huge levels of compliance with mask wearing. So I can't hunt that criticism down, because anytime Cheryl Hurd and the doctors and others are doing an incredible job. If you walk down the hall and you don't have a mask on, you're getting called out. There's nothing to that. So that's where we are with visitation right now, Amanda, and we're at this point not changing it. But if we see a need to, we will quickly do that.
Thank you.
You're more than welcome, and thanks for the call and the suggestions and the comments you and I had. I appreciate that very, very much. We do have, a few exceptions to the mask protocols, and obviously when births are involved or end-of-life situations, we do make exceptions because life or changes to life do go on, and we need to be very cognizant of that with family members who are celebrating the joy of bringing a baby into the world, or family members that are suffering with the loss of an individual. We do make exceptions. So, any other questions?
Robert, before you go on, for just for information, the ICU patients that are COVID-19, positive.
Yes.
One of the challenges that I'm sure Cheryl and the physicians and nurses have had is if they're intubated, there's nobody they can talk to get approval for various things. Like, do you want to be extubated when? Do you want to be intubated when? Are you folks familiar with what I'm talking about?
Yes, sir. And what we do is we do our best outside the walls of the hospital to communicate with those family members on DNR decisions and decisions like that. We know who the next of kin are. We have a listing of the contacts that they use for emergency purposes. And we don't, and Amanda, I should also probably clarify this, COVID patients, if you're a positive COVID patient, you are not allowed visitors. We did have that challenge at the beginning where people said, well, I'll wear a mask and I know they're COVID, but that's my risk. And it's actually not your risk, it's everybody's risk. And if we have an outbreak of COVID, we're going to do everything we can to restrict that. So if you're a COVID positive patient, you're not going to get visitors, but actually nobody's truly expected that. And to your point, Chuck, we still are doing a really good job of knowing who those emergency contacts are and family members, particularly in those tough situations.
Great, excellent.
So, Mini Chair, I don't know if there are any other questions, but I'm happy to entertain them.
We've got everything settled with the Pfizer vaccine, and we're going to get 2,000 doses of that. We expect the Moderna 2 weeks, 3 weeks.
Yes, sir.
And we think that will be a sufficient amount to cover the 4,000 or 5,000 employees that we think will want the vaccine.
There's a couple things. We have ultimately requested 10,000 vaccines, and those will be coming in increments. So when we get the first one from Pfizer, we'll get the first one from Moderna, we'll get the next from Pfizer, we'll get the next from Moderna, and it will keep going until we fulfill our full 10,000. No one is going to get that kind of one is going to get that coming, particularly when you need to spread it out for all healthcare facilities throughout the state. So we feel pretty confident at it coming in 1,900 to 1,000. And that's what we as well. But again, the state's been working personally on Roger for the next.
Thank you.
Robert, before you go on, I just want to note DT Wynn's coloration of his screen is scaring me a little bit.
You're more than welcome.
I can't see it.
Let's see where what color is
I am
DT?
in I am in a very low light area.
Wow. Okay.
DT's working on his painting.
DT, looking at that, we thought you're either in the tropical canning booth or you're in a nuclear substation, and both of those.
I'm sure it's totally legal. Whatever it is, I'm sure it's totally legal.
Are you in Colorado right now?
It's Houston Cougar color.
Okay, I thought it was burnt orange.
Well, yeah, that is true. Well, DT, one, we're glad you're here, and we're glad you're smiling, whatever color you appear to be. We're happy that you're here. We are delighted.
So, Mr. Early, if you want to continue on your report.
Yeah, I want to, usually what we're going to bring to you is an update from various departments. And we forgoed that today because at the end of the year, you're going to have a lot of contracts, and we apologize in advance. This is our toughest meeting because this is when vendors come to us and say, oh, by the way, you've got to get our contract in by the end of the year. And but our next meeting is on December 10th. And they said, yeah, we know, we're telling you. That's why we came to you on December 8th. We thought we'd give you plenty of time. So we are definitely challenged with our vendors. They drive us nuts in that regard. Not always do they drive us nuts, but right now it is the moment of nut being driven. Daphne has done an incredible job of telling staff, oftentimes to their own frustration, you have to have this in line, and you must do this, and you must have that. So I'm going to be quick about this because most of this is a statement of the obvious. But if we look at the end of the year, and we are a slight celebration that it is the end of the year, we are hoping that 2021 for you all and everybody else has a little bit of a positive, definite, different twist to it. But this year has created challenges in a business environment. The first challenge that we found in our end of the year review and looking is what happened when COVID hit and where we were with supply chain, and where not only we were, but everybody was. And it was really interesting. I'm really glad the days are over that not every one of our neighbors is a mask supplier. And we had PPE people coming out of the woodwork. And I appreciate the entrepreneurial nature of America, but not everybody actually manufactured PPEs. And it was a challenge. DT helped us a lot with that. We had others of you helping us with that, but we really found that supply chain was not as strong as we wanted to be, particularly in a crisis mode. And Sharon and the team put together a really good plan to deal with PPE, and we've not had any PPE problem. But at the beginning, that knocked us to our knees and everybody else to their knees. We started the year in a very bright way. We started the year with a new chief operating officer. And I don't want that to go unnoticed, because that has been in a year where gifts are smaller in their boxes, and oftentimes you unwrap them and there's nothing inside the box. When we unwrapped the gift of a COO, that was a huge bonus for us. And Karen Duncan has done an incredible job in one of the most difficult years I think one could have to be in healthcare, and the most difficult year to be in a lot of different professions. And as we brought Karen in, we made significant changes, and we looked at a significant supervisory role for Wanda to take, and Wanda to look at nursing in its totality, not in its segments. And we have the luxury of having a Dent in that will actually deal with the operations. We elevated Lauren Poe to look at our strategic planning, which you'll hear more about. We looked at facilities with Adam Lane and Doug Chung, looking at our labs and some of our areas that were the most challenges and asked for most of our opportunities. We still have a lot of opportunities from a lasting challenge of 2020 going into 2021. Our big challenge that we are incredibly concerned about. Wow, Roger, do you have me on a jumbo screen? How cool is that? But we want to mention that we have a lot of challenges going into 2021 for a Joint Commission survey. And we're going to be very specific with you on some of the challenges that we currently face now and what we're looking at. So from a standpoint of staff changes, I think we made some wonderful, positive staff changes with those who retired and those that just probably didn't find JPS to be the right place for them. So I want to thank you all as board members to provide that. I don't want to miss looking out at the positives. The world around us changed. Our nation changed. Racial discrimination raised its ugly head in the ugliest ways, which affected our employee base. It affected our sensitivities. It showed the kind of place JPS can be and should be. We made staff and personnel changes because people didn't understand the value of respect, didn't understand the value of what it's like to treat people not based on any other reason other than their high qualities. And so we had to tell a few people in this organization, JPS is not the right place for you because we don't have a tolerance if you cannot understand the value of working with somebody, no matter what color, no matter what age, no matter what height, no matter what weight, no matter what it is about them. They are wonderful, great people, and you will work beside them. And if you can't, then we're going to ask you to go somewhere else. I'm proud of the fact that after Dorothy and DT Wynn talked till they were blue in their face, till so many years, we have begun to make some very vibrant steps in connection management. And we've put in place focus groups to ask people what is going on with Connection, and we've looked at different ways to do it. I think 2021 will be a big year on managing Connection patients, and I want to thank particularly DT and Dorothy for their vigilance in doing that. They never gave up, and we're moving ahead, I think, in that regard. We in the area of awards, and awards do not make the world go round, but in a time of low morale and a time that is really tough to walk the halls here, getting awards is kind, and we've received a couple this year. I mean, when you as a board and we as administrators are called out to be the #1 hospital in America on 5 different categories, that's pretty impressive. And I think when we look back at our year, don't be jaded just by the tough stuff. That's a neat accolade to be told that, and then that to be followed up locally by being picked one of the most outstanding healthcare organizations by D Magazine, which is very sensitive to watching what goes on. And when you compete with the likes of Baylor and THR and really good facilities like that, and we become #1 in that, that's quite an honor, and that's quite a wonderful situation for us. So we go through this process for the year in its review. We have a lot going for us. We have a lot going for us, and I appreciate the board and the challenges that we faced by bringing Daphne Walker on board. She is a definite plus for the team to be able to walk 2 doors down and say, Daphne, what do we do about this? And having her physically located here is a plus. I don't know that Daphne sees the plus of an open door policy as the value that I see it, but Daphne is here for the team, and that's been great. I want to thank you all for how we made that transition. So this year has been a year of change, for the change we didn't ask for, and it's been a year of change in what we have asked for. And I want to thank you, board members, for your support. And when you look at the end of the year, there are some real hard struggles, and you've got an organization that is willing to take those struggles. And then you also have an organization that, in spite of a pandemic, has continued to provide the best in trauma care. We still have an ED that sees 300 or 400 people a day, and they still come in every day and work exceptionally hard. We have kept, for the most part, all of our employees whole without furloughs and without layoffs. We've not been in the position that so many of our colleagues around the nation have been. And I owe that a lot to the staff, and I owe it a lot to you as a board and your support. So I personally want to thank you, and I want you all to, if you have to squint to see the blessings, go ahead and squint. But quite frankly, many of us are not squinting to see the blessings of the last year. And what an incredible group of people. As Chuck Weber says, thank you, thank you, thank you. I agree with that statement. So with that being said, Mr. Chair, I will turn it back over to you unless there's any other comments. And DT, we are thankful that your color is a little bit better around you. It doesn't look like you're in a thermal nuclear center.
What color is it?
I have no idea, but it doesn't look like it used to.
He's no longer blue in the face. I think he's just kind of reddish in the face. Thank you, Robert. Thank you for that very much. And I look at the screen and I see so many amazing people, and Dr. Duncan and Zelia and Daphne and so many people that really enjoy. I mean, the incredible work that Joy Parker does and Laura Burnside does. I just want to thank you all, and whatever it is that Robert does. I mean, I'm sure it's important, but just the organization is. I say it time and again. I'm so blessed and honored to be associated with such an incredible group of people. So, are there any questions or comments for Robert from anyone?
I have one for you, Robert. I attended a seminar with the Texas Healthcare trustees, and one of the speakers was Dr. Anna McKee, who's the Executive VP and Chief Medical Officer of the Joint Commission. And since they will be coming to visit us sometime within the next year, her 4 main topics were, and this was pretty much responsibility of the board, which is the the reason for the meeting. And safety and quality is a strategic priority. Engagement, competence in safety and quality improvement, and transparency. So those will be things that we're sort of looking at as we go through next year. All right, that's it for me. Thank you.
That's a good point, Chuck. And as we go through next year, one of the things that JPS has been also so strong at is the certifications for programs that make the muster to be some of the best in the nation. And the two surveys that we recently had, we've been focusing on the Joint Commission, but the two surveys that we recently had on delirium and that we had on a stroke center, we are the only public hospital that has certifications in 4 major areas, and delirium and stroke being 2 of them. It's pretty amazing. And when those Joint Commission teams came in for both delirium and stroke, the accolades were amazingly wonderful. There were not deficiencies, and it's been quite a comment to the team about what we're able to do and the certifications we are able to receive at this public hospital that a lot of our private and public colleagues don't even try to get. And we step up to the plate to get those. So as we go into 2021, I think we're going in a strong measure in a lot of capabilities. I'm also pleased with how the med staff is strongly working with us. Cheryl Hurd and I speak all the time about challenges and opportunities and good things. And I think that relationship with me as an extension of you as a board and me as an extension of the organization, to be able to have those Saturday afternoon phone calls or evening phone calls with Cheryl, who's taking that back to the med staff, is a relationship that I've not seen before, and I am greatly appreciative of. Chet Schrader did a good job in starting that foundation. The other thing that's happened because of COVID that is positive is the relationship that we now have with our colleagues. When you talk to, at the beginning of COVID, we were talking twice a day, and we moved that down to once a day, then we moved it down to once a week. But we continue to have weekly phone calls with our colleagues, and we talk about some really amazing areas about nurses shortages and how many nurses did you lose to travelers and what are you all going to do in compensation and how do you help. We are having candid conversations like we've never had before. So there have been some things that have come out of this, including our efforts on telemedicine and how we're reaching out to be in people's homes that we weren't thinking about a year ago at this time. And it's all been a value add in a roundabout, strange way to our patients. So I am grateful, and you're going to hear a lot about some of our challenges and opportunities later on when it comes to Joint Commission. You're going to hear about our strategic plan, our community needs assessment. So I don't want to belabor things. I do want to move on from the agenda standpoint, but again, let me apologize to you board members by the amount of contracts that are on here. This is and Charlie knows this because Charlie Powell and I had this conversation a year and a half ago. When you get to the December meeting, it is challenge, and Sharon and Daphne both have gone through quite a bit in the last couple of weeks with all these contracts. So thank you, Mr. Chair. I appreciate it, and thank you for giving me the time to give you a sort of an end of the year recap. There's probably 7,000 things that were left off that because there are 10,000 things doing great at JPS and what we need to talk about.
Thank you, Robert. Let's move along to item number 7 on the agenda. Dr. Hurd, a report from MedExec staff.
Hi, thank you, Mr. Mini Chair. I appreciate the opportunity to address the board. At this time, we don't have any policies or other updates to send forward for approval for the board as yet. We still have a huge policy work in progress. I did want to update you all on a few things. We have completed the first 5 articles of our bylaws rewrite with the help of our bylaws expert consultants legally. And we're moving forward with ensuring we have the right reporting structure in our committees so that the organized medical staff does meet the Joint Commission standards of actual ownership and oversight of the quality of care of the patients here and their safety, and that we report that appropriately up to the board. In addition, we did have a medical exec retreat last week with a great deal of wonderful education, kind of refresh the chairs on the chair's responsibilities and the med exec's responsibilities to you all as the board, as well as given us some other areas to reaffirm that we're heading the right direction with the bylaws changes and things of that nature. And that's pretty much all I had to report, but I did want to also say thank you to the board for your support of JPS as an institution. Thank you to Robert and his leadership and his team, particularly during all of this COVID time. Thank you to Karen Duncan for chatting with me earlier today and helping clarify some things for me and letting me, update and keep everybody having, just a good communication, open communication. And thanks to Dr. Elliott and her med staff team and Dr. Hochberg for giving us the opportunities to have the right people, to give us the resources we need to do our appropriate governance for ourselves. So thank you all, I appreciate it.
Great, thank you, Cheryl. Any questions for Dr. Hurd? Okay, great. Thank you very much, Cheryl. We'll move along to item A, and we have some privileges, right? I think in closed session, is that correct, Cheryl?
Yes, it is.
Okay. We'll move along to item A, which is committee reports and action, and I'll recognize Mr. S. Montgomery for, is he on the call? Mr. Montgomery?
Be on the call.
Is he on the call?
He had to mute his mic, but go ahead.
Mini chair is now MC.
That's right. There you go. On item Finance Committee, we met in November and reviewed the October financials. I believe everybody except for Dr. Simmons was able to attend that, so I won't belabor the items we reviewed. They are several contracts and pieces on our consent agenda for today. We will review the November and December financials at our late January Finance Committee meeting. So we don't have our November numbers today. We just got them in this week, so they're not ready. They weren't ready for review today. And Ms. Clark is here to review answer any questions. Again, I think we've already covered everything, but if there are any questions for Ms. Clark, she's available for it. So I'll open it up for anyone with questions. Hearing none, we'll move along to item 8B. I'll recognize Ms. DeBose for Human Resources update.
Well, thank you, Steve. And let me start off by thanking all of the staff for their work. The HR committee, we now have Alex, and we had to have 2 meetings this time because we had about 18 policies on the consent agenda, but that wasn't the reason we had to have 2 meetings. And so what we have on the consent agenda are the 18 policies. At our meeting, we reviewed and approved the annual incentive plan matrix for 2021 and also for our payout for 2020. That ends my report. Okay.
Thank you very much. Any questions for Mr. Bose?
Nope.
Okay, we'll move along to item 9, which is a report from our auditor. And Mr. Clark is on our call today. Chris,
good morning.
There he is. Good morning.
I'm not going to call you mini chair because I want to continue to do your audit, so just call you Mr. Montgomery.
You can call him Emperor.
No, nobody does that. So.
Well, I appreciate the opportunity to visit with you this morning. I've got a brief presentation for you to go over the results of the fiscal 20 audit. As you can imagine, consistent with the theme of 2020, it was a unique year for us in terms of how we perform audits because we had to do so much of the work remotely, but your team did a great job of coordinating that with us, and we're very cooperative throughout the process. A lot more back and forth via email and phone calls and Zoom meetings and things like that, but we worked very collaboratively and were able to work through the audit process very efficiently. In your materials, you've got drafts of the audit report and the formal communications to the board about the results of the audit. As I've done in years past, I've summarized all of that information on the slides here, so that'll be the focus of the presentation today. If you want to move to the next slide, you'll see the agenda that we've got. I want to touch on a few required communications. I've got some updated ratios and things of that nature to share with you, and then I'll wrap up by talking about a couple of new accounting standards that'll be affecting you in the future, and then have a few brief comments on the provider relief funds that I wanted to share with you. If we move to the next slide, the first thing to note here, we are complete with our audit procedures. We are in draft form today to give you an opportunity to hear this presentation and to give you an opportunity to review the actual audit report. But we are complete with our procedures, and if the board moves forward with approving the audit as presented, then we'll be in a position to finalize things. Normally, we would have presented both the financial statement audit and the grant compliance audit at the same time. Due to delays in HHS's expectation of how we'll test the provider relief funds, there's a delay in completing the grant compliance audit. We're awaiting some additional guidance from HHS that we expect to come out this month, and then we would complete any single audit procedures in January or February of next year, and then we'll present those results to you once that audit is complete. But we are done with the financial statement audit and are prepared to issue a modified or clean opinion on that audit. Moving to the next slide, we've summarized here the significant judgments and accounting estimates, and also the significant financial statement disclosures that we've identified in the audit report. The significant estimates that you see are consistent with prior years. Each year we go through a risk assessment process where we evaluate the transactions in your financial statements and also look at your internal control structure. Through that process, we're able to identify the most significant risk areas in the audit. There was nothing in that was new or different this year. And so you'll see there that our key risk areas were identified as being patient accounts receivable, the measurement of your supplemental Medicaid funding, your reserves for self-insured risk, and also your net pension liability that's based on a variety of assumptions. On the significant financial statement disclosure side, these are also consistent with prior year with the exception of CARES Act related matters. Those include Medicaid reimbursement programs, the nature of your defined benefit plan, property tax revenue, and then you'll notice, if you looked at the footnotes, you'll notice a couple of pages of disclosures related to the CARES Act. There were two primary provisions in that act that benefited your organization, including the provider relief funds and Medicare advance payments. So we disclose the nature of those programs in the footnotes, and I'll have a few other comments related to those items on future slides. Moving to the next slide, we're required to disclose any audit adjustments that are recorded, and as we have done in years past, there are certain classification issues where we classify certain assets or liabilities for external reporting purposes. But nothing out of the ordinary this year other than Medicare advance payments. The Medicare advance payment program requires you to, under that program, you received about 6 months worth of advance payments from the Medicare program. You'll pay those back over time as Medicare withholds payments as they process remittance devices. And there's an extended payment program, and so there's a portion of that obligation that is in long-term liabilities and a portion that's in current liabilities. And you'll notice that on specific line items in the balance sheet. But we had no adjustments that were proposed in the current year that impacted net income or the valuation of any estimates. Also included in your materials is a schedule of past adjustments. These would be areas where we identified a variance, record an adjustment, but included it on this schedule for purposes of analysis. There were no adjustments that were proposed this year that were not recorded. The only thing that you'll see on that schedule is the turnaround impact of a prior year past adjustment that was not recorded last year that would have flushed out through your income statement this year. But again, that was not material, and there was nothing related to the current year audit. So moving on to the next slide, I want to move into some analysis of your financial statements and some key ratios. Here we've summarized, you'll notice in some future slides that we have some district averages, and these are the districts that we've included in those averages. And I thought that this, I've added some additional information to this slide this year that I think you'll find of value, particularly those last three columns where you can see your days cash on hand, the funded status of your pension plan, and also your cash to debt ratio as it compares to your peers in the state of Texas. One thing that I'll note here is that Harris County and Bexar County have different fiscal year ends, but for purposes of measuring days cash on hand and the cash to debt ratio, I've utilized their September 30 financial statements to sort of equalize those so that you've got an apples to apples comparison. Obviously, days cash on hand is impacted this year by receipt of the Medicare advance payments and the provider relief funds. And also there was additional supplemental Medicaid funding for the larger districts. But this will just give you a sense of how you compare to your peers on some of these key metrics. If you'll move to the next slide, this is a summary of your balance sheet with 2020 being in the far right column, and then we've got some historical years shown as well. The thing that will probably jump out to you here, and you've seen this in your internal financials as well, is the growth in cash and short-term investments. Significant growth there with about $137 million of that growth coming from a combination of the provider relief funds that you've received, as well as the Medicare advance payments. You also received a significant amount of UC funding this year as compared to prior years, so that also improved that cash position. And we'll look at days cash on hand on a subsequent slide. You'll notice if you're looking at the trend over that 5-year period that you've had a significant growth in assets, about a 43% increase between 2020 and 2016. Obviously, a lot of that is that growth in cash that we've discussed. But the other important factor is if you look down at net position, you'll see your net position, your equity has grown from $830 million in 2016 up to over $1 billion in 2020, which is about a 27% increase over that period. So you see a solid strengthening of the balance sheet over this 5-year period. I mentioned earlier that you receive Medicare advance payments and provider relief funds. I'll note here that you've not recognized really any of the provider relief funding as revenue yet. So all of that funding is on your balance sheet as a liability currently. And I'll talk about that more at the end of the presentation. And then also the Medicare advance payments are on the books as a liability as of September 30th because Medicare has not yet started recouping that funding. And so that's why you see that increase in current liabilities and in other liabilities, because that's a combination of those provider relief funds and Medicare advance payments that are still reflected as a liability. Next slide is days cash on hand. You'll see a big jump this year. The maroon line is JPS, so you went from 212 days last year up to 305 days this year. Again, and I sound like a broken record here, but that includes provider relief funds and Medicare advance payments. If you were to exclude all that funding from this calculation, you would be at about 260 days cash on hand, so still a nice growth from 2019 absent any of that additional funding, which puts you right in line with the Moody's AA3 rated hospitals at the end of the year. You'll see also the comparison there. It's the average Moody's rated hospital. And then that green star represents the average for those 4 largest districts at September 30th, which was about 226 days cash on hand. On the next slide, you'll see net days and accounts receivable. Last year, we talked about some of the significant changes that you made in your revenue cycle to improve the timing of your cash collections, and you were able to sustain that into 2020 as well. So you saw that big drop from 51 days last year down to 40 days in 2019. Ticked up a little bit in 2020, but still in a very solid spot, both from a valuation perspective and a process perspective. So as a board member, this would give me comfort that my revenue cycle is being managed efficiently and that my AR has not been over or understated. And you can see there by comparison to your peers, really performing better in a lot of ways. For the other districts, there's different programs related to indigent care that can impact the timing of when some of their revenue is paid. So that impacts the average for the districts. But you can see there at September 30th, an average of about 50 days versus the 42 days at JPS. On the next slide, we show your pension plan funded status. This is important to evaluate on a routine basis for any organization that has a defined benefit pension plan. The maroon bar is the funded status for the JPS plan, the blue bar being the average for S&P rated hospitals, and then that green star again is the average for the districts. You're at about 96% funded as of the end of 2020. It's ticked down a little bit, and that fluctuates with just investment performance, but still a very strong position from a funded status perspective on your pension plan. The next slide compares your cash to debt, and I showed this ratio on that earlier slide, but because you've not borrowed a lot of money, your liquidity position and your leverage position is much different from your peers in the industry. This trend really hasn't changed over the years. On the next slide, we've got a summary of your income statement over the last 5 years. Obviously, if you drop down there to the bottom line, a very strong year, $198 million net income for the year, which is inclusive of a few things. One, you had some solid growth in your net patient service revenue, but also a significant increase in that supplemental Medicaid funding that you can see went from $130 million in 2019, which was really kind of where it had been for the last several years, with a significant increase up to $265 million in 2020. That's attributable to the change in how the UC funding was allocated, which is now based on your burden of charity care costs and how that compares to other hospitals in the state. So we did see a shift in a lot of that funding from some hospitals that didn't have a significant charity care cost to the larger hospital districts that have a different payer mix. You'll also notice a slight increase in other revenue from $76 million up to $98 million. That comes from revenue associated with donated drugs. There's a comparable increase in other operating expenses related to that. So that really offsets. So really the driver this year in the change in your bottom line coming from your growth in net patient service revenue and that additional supplemental Medicaid funding. On the next slide, we compare cash collections to net revenue, and we review this statistic to make sure that you're collecting the revenue that you're recognizing in your income statement. And you can see here in each of the last 2 years, as you've improved your accounts receivable situation, you've collected some of those old accounts, and that results in a situation where you have a couple of years where your actual cash collections exceeded net revenue. But still over this 5-year period, you've collected around 101% of the revenue that you've recognized. So that gives us comfort that you're routinely recognizing revenue in an appropriate manner. The next slide is an analysis of property tax revenue, with the bars being the amount of property tax revenue that each organization gets, and the percentage reflecting the amount of support that means to the organization. So essentially 35% of your total revenues are coming from property taxes. And then you can see how that compares to some of the other districts. A couple of things that I shifted this year, some of these other districts have insurance companies as part of their organization. So I've adjusted this to just focus on the hospital operations. And then also some of the percentages changed a little bit because of additional funding that this group is getting from supplemental funding programs, and then also the Medicare DISH program. That's shifted the numbers a little bit, but relationally, these are consistent with prior years. Any questions on any of the financial information that I've shared?
Thank you, Chris. This has been really good. And, from my perspective, this was an exceptionally clean audit. I think the term I heard was squeaky clean, which is great. And I know that I want to sing the accolades of Sharon Clark and the team she's assembled. I think deserve a lot of credit for this. And so we should all be aware of that. And also want to let everybody know that I know Chris and his team at BKD have been a tremendous resource for us as we've gone through this very unusual year and trying to sort out what the federal government is intending and what they're saying and how we deal with what's going on. So thank you, Chris, for that. And thank you to your team. Any questions for Chris?
I had one comment that I wanted to make. If you can advance a couple of slides, I wanted to just briefly talk about the provider relief funds. As I mentioned earlier, you've not yet recognized any of that revenue that you've received, and it's about $87 million of funding that's come through the CARES Act. And I think I mentioned on our last call where I joined you that guidance has been changing a lot throughout the year. We now think we're at a point where the guidance shouldn't shift much, but you'll be reporting in February of 2021, and you'll claim expenses associated with COVID that have not been reimbursed from other sources. When you complete that process and you're able to measure the total amount of expenses that you've incurred, then you'll recognize revenue accordingly. So just as an FYI, some portion of that $87 million will be recognized into revenue in fiscal 21.
Okay, thank you. Sharon, are there any comments you'd like to add before we offer this up for consideration to the board?
Yeah, can you guys hear me? I've been having some audio issues this morning. So yes, I would just like to thank my team. I can't mention them all, but the person who coordinates and probably takes the brunt of the audit is Courtney Bodecker. She's our executive director and controller. So she's done a fabulous job, and we try to be ready, audit ready throughout the year. So for us, it's really closing the book and preparing the schedules. We do have a great relationship with BKD. We talk to them monthly on all accounting issues that come up. So the audit is not a surprise for us. But Karen Cruz, we also have her over running the finances of a claim. And those two really coordinate. There's probably 100 other people that are involved. And I just want to thank everybody's hard work and diligence.
Great, thank you. Any questions for Chris or Sharon from the board? Okay, with that, I will entertain a motion to accept the BKD's auditor's report for the 2020 FY20 audit.
Move to approve. Zim.
We have a motion by Mr. Zimmerman.
Second by Amanda.
Second by Ms. Arizola. All in favor of the motion, please say aye. Opposed? Opposed? Motion passes unanimously. Thank you, everybody. Thank you again, Chris. Thank you very much for your work and your help. We appreciate it much.
Thank you. We appreciate the opportunity. Have a good day.
You too.
Thank you, Chris.
We'll move on to item 10. We've got some updates. Strategic planning, Mr. Early.
Going to come to you all pretty much every month and give you information about where we are with strategic planning. And I'll begin my statements by telling you that as we have dealt with this, it is our goal as an administrative team and staff to give you all as board members a blueprint that can be changed, edited, rearranged, redesigned. We don't have the answer to it, but we thought it's easier if we can look at the daily aspects of what goes on in a health network of this size, how that interfaces with the community, and give you a document to edit rather than giving the actual document to write. That's a challenge to ask you all as board members to do. However, in that effort to get the right document, we're going to include you board members at every step of the way. And the first step of that way that we included you was the actual RFP. We went out for third-party help, and you heard me mention that when we interviewed the teams, We were a little unconventional, and we found a few people in each team that we liked, but overall, some of the teams were presenting us stuff that we thought was not as valuable to us. So we went back and we actually went to those teams and said, we would like one member of your presentation to join JPS in helping us with strategic planning. So basically, out of 5 groups that presented to us in the finals of the RFP, we actually self-selected 3 people out of those, and we put together our team. That team is working with Lauren Poe. I introduced you all to Lauren Poe at last meeting. And Lauren's role as Executive Director of Strategy and Business Development is a huge plus to us. It's a plus for the organization. It's provided strategic planning the due diligence that it needs. And we are moving forward in a very positive way. The 3 consultants have been working with Lauren both in person and by Zoom and Teams meetings. Those meetings have been very effective, and I think they're putting together a document that we can all be able to use, discuss, debate, and go forward with. What we're now going to move into is the next phase of that. Our consultants have been interviewing staff and interviewing folks about what they see as where JPS heads and what we do, and putting that voice of many into a document that has direction, that has purpose, rather than just checking off boxes. This strategic report won't be a check off the box report. It will be something that we can actually use, and there'll be contributing factors. You're going to hear after this the contributing factor that the community health needs assessment will provide for this. You're going to hear other aspects that will ultimately go into this, but this will be the document that we can look to figuring out how JPS does things in the proper manner as we begin to advance our patients and advance the healthcare organization in light of a bond and in light of facility improvements, in light of new ways to reach patients and new things to do. So you as board members will each be a part of the interview process. Our newer members, Dr. Simmons and Amanda and Zim, were questioning in a very astute and wise manner, and that is, what role do we play? How do we deal with this? You all will be incorporated along with Charlie Powell and Steve Montgomery, who will bring a different perspective to it as former chairs and also serving on this board through a variety of times, or Chuck Weber, who looked in detail about the effectiveness of the emergency room when he first became a board member, and now what he brings to the table in seeing 11 years of changes basically in an emergency room that doesn't look remotely what our emergency room looked like 12 years ago. Those are all pluses. So you as board members will be seeing that. We'll be coming to you at our February board meeting and giving you additional updates and giving you an idea as we move into phase 2 of the work, which will actually be putting those voices together and listening to what everybody said in their interviews and getting a monologue, getting a dialogue out of that, and getting some type of paper work to the actual words in the interviews. And so when you come at our February board meeting, we'll have an additional update for you until we ultimately present to you the plan. But I want to thank the board members who served on the RFP process for us. I know that was challenging because we had a lot of RFPs and they went through a good deal of work with that. So if a word of advice to you board members, if you'll stop making eye contact with me, you'll stop getting appointed to those kind of committees. But if you make eye contact with me, you're still going to be on those committees, and we do need you. So with that being said,
it helps to block his number on your cell phone so that he can't call. What I do.
Yeah, well, the challenge with that is I don't know that I'm actually calling you, but I'm calling the other board members. So I don't know what you're blocking. But to that extent, that just gives you an idea of where we are. It's going very well. The consultants are on board. A lot of the interviews have taken place with staff, and now we will begin to expand that to all of you on the board. Some of you board members have already been interviewed and talked to, but we will now extend it to every member of the board, and that process is on schedule, on plan, and if anybody would like to see the actual breakdown of the schedule, we'll be happy to give it to you, but I can assure you that it is on schedule and doing well. The next thing, Mr. Chair, is our community health needs assessment, and Lauren is going to actually outline that to you. It just happens to be falling, Mr. Chair, at the same time the strategic plan is, but they're really, in essence, two different things. It's a requirement from the IRS that Lauren will go into in greater detail and what role it could or could not play. But if y'all have any questions on the strategic plan, I'm happy to answer them prior to going to Lauren's comments on the community needs assessment.
Thank you, Robert. Any questions for Mr. Early?
Okay. Thank you all very much. I'll go to Lauren now and let Lauren explain the community needs assessment.
Excuse me, Mr. Early. That's you're not the mini chair. There being no questions for Mr. Early, we'll move to item 10B, and I'd like to recognize Ms. Poe to give us a presentation on community needs assessment. Thank you, Lauren.
Thank you, Mr. Mini Chair. If we'll go ahead and move to the first slide. So good morning, and thank you all for allowing me the opportunity to come present this information to you today. As we kind of mentioned in that executive summary that you all received last week, we've been working with a company called Premier over the last several months to complete our community health needs assessment. We also kind of outlined, just as Robert did a second ago, this community health needs assessment is an IRS compliance requirement. And it is a requirement for us to complete this every 3 years. So not only do we have to complete it, but every nonprofit hospital, as well as every public health department in the country has to complete this every 3 years. So before I kind of just give you a high-level summary of what came out of the assessment and the data, there's a couple of kind of key points that I want to make sure that we all understand before we get to that. So first and foremost, I just want to make sure we all understand the title of the requirement is Community Health Needs Assessment, but I want to make sure there's no confusion with our internal community health department. So again, this is an IRS requirement. It is looking at the community as a whole, so not our internal community health department. I just want to make sure and call that out. And you'll actually hear, Robert even did it a second ago, because of that, a lot of organizations just call it the community needs assessment rather than the community health. Secondly, even though all the nonprofit hospitals and local health departments in Tarrant County, and then of course the country, have to complete this every 3 years, we're not all exactly on the same 3-year cycle. We kind of start, at varying months throughout the year relative to what our fiscal year looks like. So we all have a different deadline, which is why each organization still completes their own community health needs assessment relative to their own 3-year deadline. Another thing is Robert mentioned earlier, but I just want to stress this point, the community health needs assessment and then the associated implementation plan, which we'll reference, is not synonymous with our strategic plan. So because organizations are required to do this by the IRS, we all completed again on our 3-year cycle and ultimately use the information as part of our overall strategic plan, but it is not it does not serve that purpose to actually be our strategic plan. And that's really what we plan to do here at JPS. So we're going to use this information, like Robert said, we're getting in the thick of really starting to work on our first formal strategic plan, and we'll use this information as part of that, but this won't be the strategic plan in totality. And then just lastly, from a semantics standpoint, just so we all kind of understand what the requirement is, the IRS requirement has 2 components. So that first component is the assessment, and that's what we're going to walk through today. And then the second component that's required is the implementation plan. That implementation plan will come back before you guys in January at the planning committee meeting. And just so you know, that implementation plan is really just meant to be a high-level summary, summarizing the significant needs that came out of what we're going to talk about today that we plan on focusing on for the next 3-year CH&A cycle. So with that, we'll go ahead and move into just, like I said, the high-level overview and summary. You can go ahead and go to the next slide. of what kind of the data showed. So this first slide, you're going to just see a quick overview of the 4 different components that are required by the IRS as part of the CHNA, but we can go ahead and move on to slide 3, and I'll walk you through those in a little greater detail. So as we move through the presentation, I'll explain these in a little greater detail and you'll understand them. But as you can see on this slide, the first component is that quantitative data component, and this is the data assessment. Again, we'll walk through in a minute really what that is, but that is then combined with the community voice, which is considered the qualitative data. Those 2 data points are then combined and ran through a priority model. That priority model is intended to really assess, out of all the different needs in the community, what are considered significant needs. And then those 3 components are what, like I said, make up part 1, which is what we're talking about today. And then part 2 is that component 4, which is the implementation plan that you'll see coming back to you in January. So the next slide. So we'll kind of start walking through those first 3 components now, first starting with the quantitative data. So if you'll go ahead and move to slide 5. The quantitative data includes different publicly reported data points associated with health factors and then outcome indicators of the residents in our community. And really the ultimate goal is to create a profile of the community we serve, to really understand the people living in our community. So as you see on this slide, these data points include things ranging from demographics to socioeconomic factors, health status and behaviors, and then social determinants. Again, we're not going to go into great detail on all the different data points. I will tell you in the full report that you were sent on Friday that you have access to on the portal and that will ultimately be made publicly reported, we go into great detail. So every single one of these data points that we looked at, you guys can have a chance to review. We break it down by zip code. We break it down on a different demographic level. We look at, diabetes by race and ethnicity, by age, zip code, et cetera. But for today's purposes, we're going to stick to more of a high-level summary. So if you'll move on to slide 6, I did kind of want to highlight a couple of the key quantitative statistics that we looked at that really provided some meaningful insight. One of those statistics that was studied was life expectancy of those different zip codes within Texas. And, one of the most profound items that this revealed was that the 76104, which I know we're all aware of after the Star Telegram report came out by UT Southwestern, but the 76104 zip code actually has the lowest life expectancy in the state of Texas. And just in general, at a high level, women had an overall life expectancy that was 5 years longer than men. And then Hispanic life expectancy was actually about 3 years longer than white and about 6 years longer than black life expectancy. Another key point that was interesting and really will be useful for us as we eventually move forward in developing our strategic plan for the organization is that life expectancy is strongly associated with poverty. And so what you can see is that those people living in zip codes that had less than 5% poverty actually lived on average about 82 years, whereas those individuals who lived in zip codes with 20% poverty level or higher only lived on average about 76 years. If you move to the next slide, you're going to really see the life expectancy broken down for the community we serve. So that was at a Texas level, and then we kind of break that down for the community we serve. This chart that you see on slide 7 shows the top 5 zip codes in our community with the longest life expectancy, as well as the bottom 5 zip codes with the shortest life expectancy. As you can see here, in that bottom 5, we have that 76104, 105 and 106 zip codes, as well as that 76119 zip code, which is the zip code that includes the Stop 6 area. So if we move on to the next slide, I want to talk a little bit about a second key statistic that we looked at as part of the quantitative analysis, and that's the Socio Needs Index. So this index combines multiple different socioeconomic indicators that are correlated with poor health outcomes. And I won't go through them all, but you can see on this slide what those are. They range everything from income, household income, to speaking only English at home, to then having a high school degree or higher education. And so each one of the zip codes then gets assigned a score from 1 to 5, 1 meaning lowest need, 5 5, meaning the highest need for socioeconomic or socio needs index. And what you can kind of see here relative to what we just talked about, and then I'll summarize on the next slide, is that many of those zip codes that are identified as being high need for socio needs are some of the same zip codes that actually had the lowest life expectancy within our community. So if you move on to the next slide, this is kind of a summary that we did to kind of round out that quantitative needs component. And knowing that there's strong correlations between socio needs and life expectancy, part of this assessment did look at combining those two data points to really determine the highest areas of need in the community we serve. So this slide just represents the top 16 zip codes within our community that are of highest need, again, based on their socio need score and then their life expectancy.
Lawrence, this is DT. How old is this data?
How old is the data? So it's actually the socio needs score was completed, publicly reported within the last 2 years, I believe. And then the life expectancy was completed by UT Southwestern, and it is actually within the last year. So that is the study that came out by UT Southwestern just a couple of months ago.
Yeah, I'm looking at UT and UT Health and UT Southwestern data, and the 76014, the life expectancy is 75.8, and Tarrant County is 78.7. And out of that, if you look at the white, it is around 74.4, and the average is 75.8. So, but there's no data for Black or Hispanic, so that number has to be higher for the average to be 75.8. So, can they update us with newer numbers?
We can go back. Again, we just use publicly reported data from UT Southwestern, but we'll definitely go back and just make sure that those numbers align. It's not something that we calculated.
I'm actually looking at UT Southwestern and UT Health data right now.
Okay. We'll definitely make that point, DT, and I'll make sure that we circle back on that this afternoon.
Okay. Yeah, the data changed so much in this year that the number actually go way up. So you may want to refresh that data.
Sure, that's a wonderful point. Like I said, we'll make sure and follow up on that this afternoon. We'll go ahead and move into our qualitative component of the assessment, and you can go ahead and move to that next slide. So as I mentioned a while ago, the qualitative component is really meant to capture just the community input and the voice of the community, really relative to what the needs are, what challenges exist, different services available in the community, and any gaps that currently exist. And one thing to keep in mind, this is really directed at a community level feedback, not JPS specifically. So even though this is our community health needs assessment, we're not looking for input related to our organization. It's really the community as a whole. So typically this input's gathered through in-person interviews, of course, and focus groups. But with COVID this year and all the social distancing requirements, we really had to deploy a few different approaches to collect this input. We still did conduct our 25 stakeholder interviews with key members both within our organization as well as the community. And I just want to pause and say a sincere thank you to Reverend Emerson and then Amanda. They actually served as two of the interviewees that we interviewed as part of this. And I want to tell both of you that that your feedback was very important and meaningful as part of this process. And so I just, again, want to thank you for that. In addition to these telephonic interviews, we actually conducted 4 focus groups virtually, of course. And these were with different individuals from community organizations representing different underserved populations throughout our community. And then lastly, we got a little creative this year, again, given the COVID restrictions. And so we deployed a third modality that we typically don't do, and that was a survey. And this survey was in both English and Spanish, and it was deployed through our Facebook page, our partners at Tarrant County Public Health Department, and then actually emailed out to patients from us directly at JPS. So we can go ahead and move on to slide 12. And I'm not going to go through all of these with you because I know you have this in your packet and you had a chance to review these, but I did just want to call out the top 3 issues that were themes that came out of this assessment. First of those being access and systemic issues. And what we mean there is really more education and navigation of health systems and just services across the community. Basic needs rose to the top. And again, this is food insecurity, housing, transportation. And then lastly, not surprising at all, health issues. So one of the things that was so profound this year compared to last year, you know, for the most part, all of the needs stayed the same. So we conducted this in 2017. The same needs rose to the top in 2017 that rose to the top today. But one of the biggest differences was just COVID and the impact COVID has had on really deepening our basic needs of the community. You have families and you have individuals now that are experiencing needs within the social aspect and basic need aspect that have never experienced that before. So it's a new challenge for them. They're not used to having, to experience food insecurity or, housing insecurity and mortgage and unemployment. So that is one of the big stark differences that I just wanted to call out between 2017 and 2020's assessment, which is to be expected. And we can go ahead and move on to the next slide. You can go ahead and move on to the next one. So as I mentioned in the beginning, the quantitative and the qualitative data that we just talked about is reviewed and put together into a prioritization model. So these 2 components are combined. There's several different, over 25 different factors that are looked at, ranging from women's health to child and adolescent, all different sections of needs across the community. All those needs are then put into this prioritization model. They're weighted objectively and scored so that we can really determine what those significant needs are. So if you go to the next, or you're on the slide, I'm sorry, you can back up one. These are the 6 areas that all those different needs were prioritized through. If you go to that next slide, you'll see how that model resulted for us this year in 2020. So the top 4 needs that you see on this screen are going to be those that were identified through that prioritization process as the most significant. These are social drivers of health. Again, those are things such as basic needs, transportation, housing, information and coordination, which is really more so around the navigation of a health system, literacy, health literacy, chronic conditions, and then of course behavioral health and substance abuse. We won't go through these in detail. I did provide you supplemental slides after this slide that really kind of explain each one of these 4 areas in more detail and what's included in them. But I did again want to at least give you that, but we won't go through that. With that, like I mentioned at the beginning of this, the last component of the IRS requirement is the implementation plan. Again, that's just a high-level overview of these 4 areas that we just talked about and that we're going to focus on at JPS over our next 3-year CHNA cycle. That summary, again, is going to come before you guys in January at the Planning Committee, and so you'll have a chance to see that there. But in summary, the most important thing, like I said, that I really want to stress about this, that Robert stressed just a second ago, is that this CHNA assessment that you saw today and then the plan you're going to see next month, this information won't stop here. We can promise you that. Like I mentioned, this data, this information you saw today, what you'll see in January is going to be used and incorporated as one, like Robert mentioned, of the many points and data points that we're going to look at as part of our strategic planning process that we're currently starting with the external consultants. And so we're going to use this again in partnership with you all to really develop a strong strategic plan for the future of JPS. So with that, I will pause there and open it up to questions from the group.
Hey, Lauren, this is DT. I have a correction. Since yesterday, the data was showing differently. As I just refreshed it while you were talking, the data you show on it is correct now. So there was a break in the data from UT from the website from UT Health that I was looking at.
Okay, perfect. I appreciate that, DT.
This is Zim. I have a question for you. In looking at your zip code map, I'm assuming that you're only looking at Fort Worth or inner city like Haltom City and whatnot. zip codes when you're covering all this, right?
We are looking at the service area that JPS services.
Well, for example, I'm shown as not being in your service area.
And which slide are you looking at? A slide?
I'm looking at your social needs index, but I live on the far west side of Fort Worth, and unfortunately I have a 76008 zip code, which is a Parker County Aledo zip code. And those of us living in this area find this difficult. In fact, every time we go to get insurance of any kind or do any business dealings or call for service, we have got to watch out that we don't get tagged as being out of county. Another example is when I go to get a ride to the airport, where I live right now, it's $30 more than if I was to go a mile in towards the city and then get the ride. So I just don't know whether you realize it or not, but you are excluding Fort Worth citizens. Walsh Ranch is building big now, and most of it is outside of Tarrant County, but it is Fort Worth. So I don't know how we're handling this, but it's something that we need to be apprised of and kind of be aware of, because it's going to become a growing problem as the city expands.
Well, to that point, Jim, and it's probably a much bigger discussion, but where we're going to debate this is it's the Tarrant County Hospital District. So where Fort Worth is secondary to the actual confines of Tarrant County. So if Fort Worth happens to be in it's in part of Denton County as well, our service model, based on the policies of the organization and many of us that came before us, only actually provide services and care to the citizens of Tarrant County. So if you're actually in Parker County or Denton County or Wise County, we have the same challenges in Burleson, where Burleson, the city, is split 1/3 to 2/3 between Johnson County and Tarrant County. We're only providing those services and care at this time to the citizens of Tarrant County. So Walsh Ranch is going to be all Parker County. So they're not left off of our system. We only count Tarrant County, not citizens of Fort Worth.
Okay, I understand what you're saying, but still, again, I am not in Parker County. I'm in Tarrant County, and you're showing me as a non-entity on the charts.
No,
that's the issue.
Yeah, and I get that you would be, but I don't believe that the Walsh Ranch and all that population is going to be out there. So for those of you who have a traditional, Willow Park, Aledo, or Denton zip code, that we need to be very cautious about. But when you mentioned Walsh Ranch, I don't think Walsh Ranch is Tarrant County.
You're correct. Most of Walsh Ranch isn't. There is some of Walsh Ranch that will be in Tarrant County.
Yeah.
But it's going to carry a 76008 zip code. And so anytime you call for services, it shows up as Parker County. I am in Tarrant County, and I know I am because I was able to be on the Fort Worth City Council.
Right. And for those of you that are in that situation, we will definitely be conscientious and concerned with that, so that you're not lumped in, not you individually, but I guess in this case, yes, are not lumped into a Parker County view. And we'll do the same, looking very closely at the Denton County lines and the Johnson County lines, to make sure that there are not people with a zip code who are actually Tarrant County residents but live in a city which is located within another county. So your point's well made, but it is going to be some numbers. It won't be the largest of numbers, but we will look closely to make sure that we're as accurate as possible on this and when it evolves up into the strategic plan.
Okay, I just wanted to point that out, that it's an issue, a very small issue on the west side of town, but it is every bit an issue.
Yeah, no doubt, and it well taken, and I appreciate it. We will look closely at that.
Okay, thank you.
You bet.
Any other questions for Lauren?
Hey, Lauren, this is Amanda. Just a quick question on the focus grouping on here. You have 19, was that 19 focus groups or was that the number of participants?
That's the number of participants that were involved in the 4 different categorized focus groups.
So that's a total number of participants in the focus grouping?
Yes, yep, yes ma'am. The 19 is total number of participants.
Has that been historically the number of focus group participants?
It's very close. So historically, the focus groups, again, were in person, and they were in a community setting. We actually did fewer focus groups in the past. So we would do, 2 to 3, and we would get, roughly 7 to 8 per focus group. So the total number of participants is about equal to what we've seen in the past.
Okay. And same thing with the survey number of participants?
So we've never done the survey before. That was actually an additional add this year due to the COVID and the social distancing restrictions, trying to get additional voice of our community. So that's something new we added this year in light of COVID.
Great. And you said we're going to get the full report in January?
So the full report of the assessment is actually available to you now. I believe it was uploaded in the portal as a reference document. So you should have access. If you do not, I will make sure that we get that sent to you all today. And it's actually going to be posted by the end of the week publicly on our website, because that is a requirement of the IRS. And so we will be posting that by end of week.
Okay, wonderful. Thank you.
Yes, ma'am. Thank you so much.
Any other questions for Lauren? So, Robert, this may be a question for both you and Lauren. As we develop plans to address these findings, as we ramp up into budget season coming up in the spring and summer, I guess some of the plans will inform our budget. So I just sort of put that on your radar screen because I'm sure Sharon will start having her budget meeting coming up soon. So whatever we can implement obviously will be driven somewhat by budget.
Yes, Mr. Montgomery, you're exactly right. It's actually our hope that, again, this new strategic planning process that we'll be developing will really help to align all of those things. So it will help to align the information coming out of the CHNA, but then also other strategic information data points that'll go into, again, this new process Robert mentioned a while ago into, January, February, early spring, that we hope will help to inform our overall budget for FY22.
Fantastic. Great. Any other questions for Lauren? Okay, thank you very much. I'm sorry, yes.
Obviously, Mr. Montgomery, Sharon is texting you during this meeting. So thank you for letting us know that those need to be incorporated in the budget. But we will.
It's been properly trained. I was not texting.
Yeah, well,
so he
none
and
of us
I
knew.
are on the same wavelength here.
None of us knew that there was proper training for him, but nonetheless, we will definitely incorporate that into a budget process. And the other thing, Steve, that's important for you and the board members is this is a larger viewpoint. When it gets to the strategic plan, it will be far more specific, and you'll see actual patient data connected to a plan that will go directly with it. So the assessment is really good for us, but it will really focus into our strategic plan, and that's where you'll see a lot of specifics. So thank you. I appreciate y'all on listening to that.
Thank you much. Thank you, Lauren. We'll move on to item C, which is Wanda Peoples is going to give us a staffing effectiveness report. Wanda, are you there? There she is.
Can you hear me?
Yes, we can.
Okay, great. Well, good morning. Those of you who've been on the board for a while probably remember this is a report that I bring to you every year. If we could get the slides up, please. There we go. Thank you. This is required by the Texas Health and Safety Code. It's also required by the Board of Nursing. And it's also a leapfrog requirement that I bring this information to you every year. And what we do is we look at, or we're required to look at some different indicators. We're looking at nurse staffing concerns and nurse sensitive indicators. Next slide, please. Our nurse sensitive indicator measures We look at falls with injury, we look at pressure injury, and these indicators are distinct and specific to nursing. These are things that nursing has a direct correlation to, unlike medical indicators, which look at medical and quality of care outcomes. We also look at some human resource indicators, such as our nursing hours per patient day, our overtime percentages as a result of productive hours, and our report from our nurse staffing committee. We benchmark against NDNQI, which is the National Database of Nursing Quality Indicators. Next slide, please. This is a slide indicating our nursing hours per patient day. And what that does is it measures the average number of hours needed to care for each patient on any given unit. This indicator is something that you don't want to be too low and you don't want it to be too high. You don't want to be not using enough nurses, but you also don't want to be overshooting the care you need to be providing. And we are really right where we need to be. You can see our numbers down here. According to the database, we're all in the green. So we're right around the 70th percentile, which is not too high, not too low. So we're doing a really good job with that. Any questions around that? We have had a slight uptick in 2020 based on the care of our COVID patients. We are seeing very high acuity with many of these patients requiring 1-to-1 ratios, but you can see according to the graph, we're not the only ones seeing that. I think that's a trend around the country. Next slide, please. This slide is also, this is not necessarily compared to NDNQI. It is compared though to our own internal benchmarks. It shows our overtime percentage of productive hours. Again, we did see an increase in overtime as we've tried to cover additional shifts due to acuity and demand with our COVID patients. We also increased our numbers of beds with COVID. We opened an additional intensive care unit. We have an average around, right now, we have about 15 patients in there, in addition to our regular ICU. We've also taken one of our PCUs and converted that to a COVID unit, and we have doubled beds on that unit. So instead of having 36 patients at one time, we had up to 60 patients there. We're averaging now around probably about 45 to 55 patients there on any given day. So those numbers were not built into our budget. So we've had to utilize some overtime and other means to do that, to staff for these patients. Some other things that we have done is we have hired some agency nurses ourselves. We've also received some state issued nurses to give us some relief for our own nursing staff. And we've lost some nurses this year. Some have decided to go traveling where they're paying these really high dollars to get nurses to go all over the country and work. And some of those have, especially some of the younger ones that don't have family commitments and all that, have reached out and done that. We've lost some others due to health concerns, and then of course just regular attrition of those getting transferred or like spouses being transferred, moving out of the area, that type thing. So that's one of the reasons for our increase in overtime percentages. Next slide, please. So how do we monitor that and make sure that the staff are doing well? And that's another requirement by the state board, is that we have a nurse staffing committee. This committee is made up primarily of 60% of bedside nurses. They are selected by their peers to represent them on the committee. The CNO, some of the directors, managers, and team leaders also serve on this committee. We also have representation from HR, our nurse recruiter, and someone from quality services. And this committee needs to meet at least quarterly, and they go back and they look at what were the staffing concerns expressed by the staff, Did we see any trends? Did we see any best practices? And we compare, what's one unit doing compared to another that they can share with each other. We have a website on our nursing page where nurses can go in if they arrive on their shift and have concerns about either their assignment or their staffing on that shift for the day, where they can go in and notify us. And then the team member assigned to their unit does the first follow-up, gets with the manager, and they do an investigation of why there was concerns with staffing on that particular shift. So that's, like I said, we go back, we review those, we bring them all to that committee, we track and trend them, and we try to look at what we're seeing as a result of that. Next slide, please. So, like I said, these concerns they're anonymous, or if they want to be, they don't have to be, but they can be anonymous. Next slide. These are our submissions for this past year. And this is an effective committee. I just want to stress that. When I first got here, we were having a lot of submissions, just about every shift. And a lot of that was coming from our PCUs and critical care, and that was regarding their staffing ratios. They had a 4-to-1 ratio at that time, and those are very sick patients because we only have 36 ICU beds. Many of those patients are moved out of ICU and into those PCUs. So you would see these type patients in an ICU in other hospitals. So the nurses came forward with their concerns, and I was able to come and present that to you, what their concerns were. And we were able to, through your approval and in the budget, to get those ratios changed to a 3-to-1 ratio. So, like I said, it is a very effective committee, and it's been great to be a part of, to work with these nurses and hear their concerns. You see a couple of blips here. There was a blip in March. That is right when we went into COVID. And it really hit the behavioral health areas hard. And so our PEC, our psych ED, most of those submissions were submitted on 1 or 2 different days. And as a result of that, Zelia and her team set up a second PEC over in the Trinity Springs division to try to socially distance and make sure that we had the right ratios and staff available to care for those patients. In September and October, we had another kind of blip where we had, and most of those submissions again were submitted on the same day or two, and that is when we decided, as a result of spikes we were seeing, to double our patients up on P5. We had some communication opportunities there and some staffing concerns from our staff, but once we got things communicated and relayed their fears, then that issue was resolved. Any questions regarding that? Next slide, please. So some of the things that we've done this year to work on staffing and to try to reduce our overtime is, of course, we've worked with our talent acquisition team. Dina and I are meeting with them sometimes several times a week, looking at our recruitment and retention efforts. We really focused on recruiting for our internal resource pool. We've increased our job fair frequency because we're getting in resources from agencies or from the state. We've added additional orientation dates to make sure that we're expediting and onboarding the staff as timely as we can. We reached out and hired PRN and seasonal nurses, and what seasonal nurses are nurses usually who work at other hospitals that want to pick up extra shifts. And so and they can work at a higher rate by doing that. And so we've been able to pick several of those up, which is great. And we did get approval for, at one point, 90 additional support staff from the state, and then we went back and added some more. It's kind of been a revolving door. Some are coming, some are going. But we're in the process this week of adding several new ones that are coming in. So that's been exciting to get that additional resource from our state. And so that is greatly appreciated. and is giving our staff some support to help them from having to do so much overtime. I will say I'm so proud of the team that we have. They have stepped up and just done an amazing job. They're exhausted, they're tired, but they continue to come to work every day and provide excellent care for our patients. Mr. Early mentioned earlier, we had 3 surveys this year, big surveys, our AMI, our stroke, and our delirium survey recently. And the engagement of the staff for those surveys, and each surveyor commented on them. And you'll see with our outcomes when I present those here in a minute, they've not missed a beat. Our outcomes, despite all they've been through, have remained very positive. And so they continue, even with all of this, to give excellent patient care. So I just can't commend them enough for all they've done. We've also reinstituted a referral bonus. So we know that the best word of mouth. So we have team members who have worked at other hospitals or know people who work at other hospitals. So if we can get them to grow out and recruit staff to come in, we will pay them a referral bonus for bringing those people in. We'd much rather pay them than pay an agency. And we've also really enhanced our social media platform and our network platform to try to go out and recruit other nurses as well. Any questions regarding that?
Any questions for Wanda?
I'm not on this particular thing. I got a couple more slides and I'll be done.
Okay, all right.
Next are our outcome indicators. This is our falls per 1,000 patient day, and this is a slide I'm extremely proud of. We are doing some of the best in the country. This is one of those slides where you definitely want your numbers to be lower, and we are definitely in those. And the injuries that we've had actually in 20, first quarter and second quarter, there is a lag time with NDA and QI of getting this data, but you can see we're all in the green down here with our numbers, and the injuries we have for this fiscal year have been very minor, like abrasions, bruises, some lacerations. We did have one patient who fell out of bed and fractured a couple of ribs. But for the most part, our falls with injury have been very minor injuries this year. So next slide. Some things we're doing to prevent falls. This is not something that just happens. It's because there is a lot of work around this. We have increased our use of telesitters. We have done extensive training with our nurses at our skills fairs and on hire as they come into the organization. We've done a lot of training around any medications that could put patients at risk for falls. You remember you also approved recently updating our whole fleet of beds that we have, and those new beds have bed alarms. And I'm really hoping that these low numbers that we're seeing with the falls as a result of some of that with the bed alarms. So thank you again for that approval. It's showing that it's paying off. We also make sure we're using keywords at key times when we're doing our hourly rounding, reminding patients, you know, call, don't fall, you know, call us, don't get up without assistance, reassuring, making sure they have everything that they need within reach before the nurse leaves the room or offering to take them to the bathroom. So really working on that. And then we also put in a new cost center to look at our tech utilization and our patient safety assistants. We're changing the name of those recently to constant observers. And you did approve additional FTEs for that. So we're working now to get those positions filled to try to keep some of these patients from getting up and falling because the Joint Commission and we do not want to have to, we can't really restrain these patients. So that's a way that we can keep them from falling. Next slide. And then the last indicator I want to present is our hospital-acquired pressure injuries. We've not seen a spike despite COVID and all that we're going through. The ones that we have seen are primarily with a lot of the COVID patients. These patients are, we keep them prone, which is on their stomachs, they're on ventilators. And so a lot of the pressure injuries we have seen, when you think about pressure injuries, I know a lot of people go and originally used to think about bed sores. That's not really what we're seeing. We're seeing most of the things we're seeing are things like our ET tube ties are causing rubbing on the ears or something like that, or O2 tubing is causing irritation at the nose and causing breakdown. So, and then also our new beds, we feel like is really helping also with this for patients who are bedbound, really helping with the integrity of that. And then we've also implemented we have a program you just approved in the budget this year is our early mobility program for our ICU. Patients that you normally would not think could get out of bed, we're really working to get these patients out of bed, even if they're on a ventilator, and getting them up and moving to prevent those type injuries from happening. Next slide, please. A couple of the highlights I want to mention, I'm not going to read this whole thing to you, but some of the things that we're very proud of is, of course, the additional education that we're doing around this. I mentioned the early mobility, but we have a LEAF program in our ICU, which is a turn program. You put I think I've mentioned this to y'all before. You put a sensor on the patient's chest and it tells you your degree of turn and if your turn is adequate to prevent pressure injuries, and then it gives you a rating on that electronically on a computer. And I have to say, or I'm very proud to say that our scores are the highest in the country for our LEAF turning and compliance with that. We also have implemented a skin wound assessment team, which are nurses from every unit that have received advanced training for preventing skin injury. And then we also have a new program, what we call it All Hands on Deck, where when a new admission comes in, as many nurses are available or team members that are available go in and assess that patient from head to toe. So we make sure that there's no breakdown, because we found in the past we were getting charged with breakdown that was actually occurring before the patient even arrived on our unit. So if it wasn't documented, then we were getting charged with that. So that's a new thing that we're doing, and it's been very effective. And then some of our OR staff went before COVID to a training program and came back with some really great ideas and things that they learned about positioning in the OR and how, especially for these really long cases, to prevent breakdown in surgery. And then lastly, we have some clinical resource nurses that are quality nurses out on all the units, and we had all of them go through and get certified in obtaining wound care certification to also make sure that we're taking care of these injuries as well. And that concludes my presentation, unless any of you have any questions for me.
Thank you, Wanda. That was a very good report. I'm really glad to see it. You know, when we think about what we are as an institution, we're not buildings, we're not, you know, not the board, it's not the C-suite. It's really where the hands meet the patient, and that's the staffing level. So it's just phenomenal to see this report. Thank you very much for your leadership on this. Any questions for Wanda on any of this?
Mr. Chair and members of the board, I would let you all know, and I'm sure I'm violating something here, but Sharon and Wanda are both significantly under the weather, and that'll give you an idea of the kind of staff we have here. They both would probably want to feel like being any other place, including being undercovers in jammies, but I am greatly appreciative of both Sharon and Wanda, because they don't even question it. They just say, I've got a report, I'll make it, I'll be there. And that's the kind of people I get to surround myself with.
Thank you, Robert. Thank you, Mr. Montgomery.
Any other questions? Okay, we're going to move on to the approval section of item 10, which Ms. Clark, I know you're under the weather, but appreciate you being here. If you're on deck for item A.
Thank you. Can you hear me?
Yes.
Can you hear me?
Yes.
Okay.
Can you hear me?
it kind of in and out there for a minute. You know, Robert, there was no way I was going to miss this audit report, so you gave me a little bit too much credit on that, but thank you. It's just not been a real good quarter for me health-wise. If you turn to my first approval item, it is, I'm requesting the archiving of a policy, LDF 6100, which talks about the health fund policy. Just a little background, because you're going to see me requesting policies over the next few months. We are doing an in-depth policy review, as you could probably tell by the HR committee and those policies. But I have asked my staff to specifically take some quality time. And if you have to read the policy once or twice, we need to simplify it, we need to use clear language, and we really need to make it our policy and procedures that we are doing today. So this policy 6100 is actually, there is no longer a board designated health fund. It is called something different, and we address that in the next policy that I'm going to talk about. So I'm requesting the archival of 6100.
Move to approve.
Oh, great. We have a motion by Mr. Zimmerman.
This is Dorothy, second.
Second by Mr. Bose. Any questions before we vote? All in favor of the motion, please say aye.
Aye.
Opposed? The motion passes. Thank you. Ms. Clark, item B.
Thank you. This is policy LDF 4100, which addresses our cash and temporary investments, restricted investments, and board designated investments. There's two major changes to this one. First of all, this policy is old enough where the policy and procedure were together in the same document. And at JPS, we lift up the policy for board approval, and then the procedure is attached underneath the policy that does not require the board approval. So this is the major change to 4100. There is also 4101, which is the procedure that is out on the board portal for your review. The one major change there, besides some major cleanup and simplification of that language, is that we had originally had 135 days cash on hand requirement. I did change that to 180 for about 6 months of cash on hand. During some of the master facility planning discussions, we have targeted about 200.
Any questions for Sharon on this item? Just a reminder to everybody, we approve policies, but the administration approves procedures, correct?
Correct. But I did want to point that out, that that was a change that was made to the procedure.
Right.
Okay. All right.
Any questions? Okay, entertain a motion.
This is Dorothy.
Charlie, I'd move for motion.
Charlie, I think Dorothy beat you.
That'd be
Dorothy.
fine.
Okay, move approval of LDF 4100.
With
a motion by
I'd second.
You're a wise man, Mr. Powell.
I'll follow Dorothy on any occasion. Go right ahead.
We have a motion by Mr. Bose, a second by Mr. Powell. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you. Item C, Ms. Clark.
These next three contracts are all supply chain related. Some of them are quite large. I did want to introduce Tom Fisher, who is on the phone. He's my lifeline. So before I called a friend in the middle of one of these contracts, I did want to tell you a little bit about Tom. I don't know that he has officially joined us at a finance committee meeting before. Tom joined us and relocated his family I believe the last week of March, which if you're a supply chain or if you're a living person, you know that the last week of March was pretty hectic when it came to this job function. He came from Bon Secours Mercy. He was there for about 8 years, but we are very lucky to have him. So Tom, you can say hello, so you'll pop up on the screen.
Hello. Hello, nice to meet you all.
Hello, Tom. Welcome.
Hey, Tom.
Hello.
So I really do appreciate his efforts here. He has really gotten through some very tough, nail-biting times, quite honestly. Our first request for approval is the Medline contract. Now, Medline is a prime distributor, so we do have our overarching GPO with Vizient, and Medline is how we take delivery of about $25 million worth of those goods. They make daily deliveries to us. We can place an order by noon. It'll be here by 8 p.m. And it is an incredibly important function that they provide for us. So this is a 3-year term. We did go out for RFP, and we're projecting to be able to save about $1.6 million on this contract.
Okay, any questions for Sharon or Thomas? Hearing none, I'll entertain a motion on item C.
Recommend approval.
Motion by Dr. Weber. I hear a second.
David, Charlie, I'll second.
Second by Mr. Powell. Thank you, Mr. Powell. There being a motion and a second, all in favor, please say aye.
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 Those opposed? Hearing none, motion passes unanimously. Thank you. Item D, Ms. Clark.
This contract is to extend the GEP services and actually change them a little bit. GEP is a consulting group that joined us on April 22nd, shortly after Tom arrived. And they were able to help us procure PPE. They were able to assist us in establishing some inventory levels and really gave us some data-driven information that we could use and stabilize. So this contract would be for them to come in, and if you looked at the contract, there's 5 major things. They're going to elevate the procurement. We're going to look at our org structure. We also want to go more to a centralized model where departments are doing less and supply chain is doing more. Train on best practices, support procurement tools, and enhance our data. And then also drive savings. There's a lot of opportunities out there, and they're going to help us evaluate those and prioritize those items. It's a 3-year contract, $1.2 million for in the first year. We can extend it. We do have to give them notification to extend, but we would not have to go back through this contracting process. So I've called it out here as a 3-year potential contract at $3.5 million. And they are a certified MWBE.
This is Dorothy. I have a question on this one.
Yes, ma'am.
Is this to bring this in-house eventually, or is this a plan for us to continue with this? And the second part is, I know you said it was a projected cost. What do you think we're going to save based on this contract, based on what we're paying? Okay.
So I do know there's going to be savings, Dorothy, but because we haven't gone through that, I'm not sure. Obviously, the goal is to pay for itself and more. And we do have a couple of projects that they helped us kick off. One of them is the that will provide several $100,000 of savings each. So I do feel confident that we will work towards the cost offset and even try to accelerate that. So that's your last question. Your first question, we do expect to be able to set this up and then bring this all in-house. Some of it will require changing the way that we do things, and they're here to help us with that. I'm truly hoping that this is a 12-month contract and we'll be able to make all those changes within the next year.
Okay. All right. And how, I will ask one other deal that on this, I know you don't have the cost, but somehow you would come back with finance on a quarterly basis and give us that cost information as it's defined.
I'd be happy
Steve, are you okay with that?
Yes, ma'am. Yes, ma'am, I am. That's a good idea.
Okay.
Thank you, Dorothy. It's a great idea.
Okay.
DT, any chance we can, any chance before we renew, if we intend to use them longer, can we go for an RFP process? I'm sure they're doing a good work, but I'm not comfortable with no RFP.
This was done. This was an RFP. We had 8 respondents and GP was selected.
Okay. Oh, it is. Okay, thanks.
Yes. You're welcome.
Okay, any other questions for Sharon on this? Hearing none, I'll entertain a motion on item D.
Zoom motion approval.
We have a motion by Mr. Zimmerman, a second by Mr. Nguyen. All in favor, please say aye.
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 Opposed? Hearing none, motion passes. Thank you. Item E, Ms. Clark, you're still on deck.
Thank you. We are asking for approval. Halyard supplies our gloves here, and we use a lot of gloves. Due to demand in the marketplace, they have given us notification of a price increase. Although this is a price increase, it allows us to keep our minimum weekly shipments, and those shipments actually cover our current utilization. The price increase does not take us up to what it would cost going out into the market, so it's still a good price, but due to demand, they are implementing a price increase. We have 2 months left on the original contract, so we'll be renewing the glove contract soon, and you will see this back in a couple of months, most likely. And we are asking for an exception to bid. They are a GPO vendor. And this is the second price adjustment. We had one in August, and then this one will be effective January 1st. So $389,000 is the total cost of the gloves for the next 2 months.
A whole lot of gloves. Any questions for Sharon?
I'd be able to come back next month and say we got another price increase, or you locking this in for any period of time, or we can't?
In this contract, Halyard has the ability to cancel the contract with a 30-day notice. They do still provide us with a below market rate. And again, we are getting our guaranteed minimum shipment each week.
Okay, so the answer to that is they can come back and increase it whenever, okay?
Yes, ma'am.
I think that's what you're saying. All right, thank you.
Yep. But they have, within 30 days, right? They can, that's a good point.
I mean, we were not subject to a price increase until September 1st. So we went from March to September with them honoring the pricing from our original contract, our pre-pandemic contract. And then this would be the second one 4 months later.
Okay. All right. Thank you.
You're welcome.
Any other questions for Sharon on this item? Hearing none, entertain a motion.
This is Dorothy, and I'll move approval of the exception to the bid and approval of the amendment.
Thank you, Dorothy. We have a motion to the exception to the bid and for the approval of the item. Do I hear a second?
Second.
Second by Mr. Nguyen. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, everyone. Thank you, Sharon.
Thank you.
Laura Burnside, item F.
Hi, good afternoon, everyone. Thanks for having me here today. I'm here asking you to consider approval for a professional service agreement for our patient experience and CAPS survey distribution between Press Ganey and Tarrant County Hospital District. The contract is the result of an RFP. We had 5 respondents for that. And we chose Press Ganey because they offered the lowest price and the highest value for meeting the current and future needs of the district. Making this change will allow us to have an incremental savings over a 5-year period of about $2.2 million over our current vendor. And that cost savings actually comes with the ability to utilize the same inpatient survey and a very similar outpatient survey, and also allows us to compare ourselves with a larger database of academic medical centers, regional hospitals, and public hospitals as well.
I thought we had used Press Ganey before. We are currently using someone else?
We are. Some of you may recall, about 6 or 7 years ago, we actually used Press Ganey for the administration of our surveys. And at that time, we found that the surveys were distributed by mail, which was problematic to us for our population. And to conduct phone surveys through Press Ganey at that time was really cost prohibitive. And NRC was working to gain market share and provided that service to us by phone for a much lower cost. But over time, their costs have increased significantly, and so it makes sense for us to go out for RFP and select this vendor at this time.
Great. Any questions for Laura?
So does this also mean that they're going to utilize just telephonic surveying, or is this additional? Because I know we had mentioned my chart previously and how there were surveys.
Yes, so they actually provide email surveys and text messaging for surveys, and then phone surveying as well. And they do mail surveys, but again, that does not seem to work very well for the patients we serve.
Thank you.
My pleasure.
Any other questions for Laura? Hearing none, I'll entertain a motion on item F.
Move for approval.
Motion by Mr. Nguyen.
This is Dorothy, second.
Second by Mr. Bose. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes unanimously. Thank you, everybody. Oh, sorry.
Mr. Chair.
Yes, sir.
I'm going to abstain from the vote. I'm going to abstain from the vote.
Yes, sir. We have an abstention by Mr. Nguyen. Thank you for that. Okay, but the motion passes, so we'll move to item G. Dr. Elliott.
Hello, good afternoon, everyone. It's good to see
Hello.
you.
You're bringing us some money. You're bringing us some money. I like it.
Yeah, so I'm very pleased to actually present this to you as the board for consideration of approval of the Graduate Medical Education Formula Funding Agreement between the University of North Texas Health Science Center and Tarrant County Hospital District. This is a continuation of previous agreements that we've had in place. However, with this agreement, we actually noted and negotiated an increase in terms of the percentage that would be paid to JPS based on the state GME formula funding per medical resident per year. So previous contracts were at 80%. We are at 90% and continue to work very closely with our UNT Health Science Center partners in looking at how we utilize this and support all of our residency programs here. So I am seeking your approval. As you see, there is revenue here. This is revenue coming in, additional and over a 3-year contract term.
Great. Any questions for Tricia?
This is Dorothy, move approval. Good contract. Okay.
Great. Motion by Mr. Bose.
Second, DT.
Second by Mr. Nguyen. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, Dr. Elliott.
Thank you so much.
Ms. Parker, item H.
All right, good afternoon. So I'm seeking approval for an agreement between JPS and the county. And what this is the county will be reimbursing us for the cost of flu vaccine administration. I think in our past subcommittees, we talked about a flu vaccine that was received as part of the COVID CARES Act funding. And these flu shots are used for uninsured and underinsured patients in Tarrant County. And again, this is a reimbursement to JPS for the administration fee for those flu vaccines.
Joy, let me make sure I heard that right. The county is reimbursing us?
Yes.
Shame on you, Steve.
Just seeking clarification on that.
Steve,
Thank you.
I have a question.
Yes, sir.
And this is for Joy as well. It says the actual flu vaccine doses are covered under another agreement. So this is just for administrating.
Yes, sir. If you remember, and it's in the consent agenda, well, from the last items that we in our subcommittees, but we actually help public health as far as procurement of the flu vaccine, and they paid us at cost for that flu vaccine. This funding is through the COVID CARES money that was made available. So through that, the flu vaccine was purchased and we were reimbursed at cost for that flu vaccine purchase. And this, just due to timing, is the reimbursement for the administration fees of those flu vaccines.
Great, thank you.
Any other questions for Joy? Entertain a motion on item H.
Oh, I did have one question.
Yes,
I'm sorry.
Yes, ma'am. No, yes, ma'am.
Sorry. I was on here. It says that it's up to 20,000 flu vaccines. I know they all have already administered about 6,000 from previous conversation. I'm sure it's probably more by now. Is that 6,000 in this 20,000, or is it an additional 2?
So we have been tracking and trending the vaccine administration through this program to date. So it's up to $20,000 if we get into a situation where we're requiring some additional funding for additional vaccine made available. We can definitely go back to amend that. But from my understanding, that initial vaccine that's already been distributed is being tallied, reported, and we work with our finance department and then public health for that reimbursement and monitoring of that administration.
Yeah, it just says it's to obtain up to 20,000 flu vaccine to be used in this effort. So my question is,
I hear you, Amanda. You're cutting out.
Amanda, you're breaking up a bit on your mic.
Okay, let me see. So it says that it's 20,000 vaccines and that it's up to 20,000 doses of vaccines, not the funding part of it. So I know that the already 6,000 that has been distributed, administered, does that 6,000, is that included in this 20,000, or is this an additional 20,000 doses?
So the 6,000, and I'll have to get back and reconcile with my team, Amanda, just to make sure, if it is 6,000 doses that were part of this COVID CARES flu vaccine, then that would be counted towards that 20,000 doses. And so that reporting will occur monthly of the kind of the reconciliation of how many doses and then the request for reimbursement. And then as we near that amount, if we feel that it's necessary to procure more or to amend to increase that funding, we would go back to public health and work with their team to make that amendment in the agreement to increase. Does that help to answer?
That's helpful. Yes, that's helpful. My only concern as we're looking at what the vaccine doses look like is that we have over 47,000 individuals on our Connections program as well. And there's the 20,000 doses for the flu vaccine. So in looking at, and I know not everybody takes that vaccine or wants that vaccine, but being able to look at the amounts that we hold and are for reimbursement when we're looking at these agreements.
Absolutely, Amanda. And I will say too, when this funding from the federal government became available for this in October to November, we had already given out, as part of our flu campaign, over 30,000 doses. So many of the JPS connections, which we were very intentional about, had already received a flu vaccine. And certainly we were very appreciative that this funding came forward. But certainly it was definitely a little later than what we had already started from a flu campaign. So I do imagine that majority of those connections have already received a flu vaccine, if that, to give you some comfort around that number.
That gives me more information. Thank you for clarifying.
Thank you, Amanda. That's very helpful. Any other questions for Joy?
Move to approve, Zim.
All right, we have a motion by Mr. Zimmerman. Do I hear a second?
Second by Amanda.
Second by Mr. Arzola. All in favor of the motion, please say aye.
Aye.
Aye. Opposed? Motion passes unanimously. Thank you, Joy.
Thank you.
Item I, Mr. Lane.
Happy Thursday, everyone.
Thursday, you.
I'm here to bring forward the exciting contract for services and maintenance on our automatic door operators across the network. Actually, this is the first of many contracts that will be coming that address our Joint Commission findings. And the exciting part about this is that this is the first contract that starts to set us up for continual readiness instead of a cycle of not being prepared and then preparing very quickly. It is a 5-year contract, 3 years with 2 one-year renewals, $168,000 a year, $138,000 over 5 years. Does have a 30-day out, and it did go through the RFP process.
Okay, we have a lot of those doors, I see.
We do.
Any questions for Adam? Do I hear a motion on item I?
This is Dorothy. Move approval.
Motion by Mr. Bose.
Second.
Second by Mr. Wynn. All in favor of the motion, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously.
Thank you, everyone.
Lane. Thank you.
Mm-hmm.
Item J, Dinah Dent. Dina Dent. Dinah, is it Dinah or Dina?
It's Dina.
Dina. Thank you, Dina. Item J.
Good afternoon. I am asking the approval for the board for our first item, which is exception to bid, an instrument and accessory purchase agreement between Intuitive Surgical, Inc. They are our only company that supplies our instrumentation and supplies for our Da Vinci robot.
Okay, any questions for Dina on this one? These are our robot, right? Equipment for our robots?
Absolutely. Yeah.
This is Dorothy. Move approval.
Okay, we have a motion by, it's just a exemption.
Oh, it's two. So
it's two. It's
approval for the exception and for the purchase of the instruments.
Okay, we have a motion, 2 motions from Mr. Bose. Do I hear a second for those 2 motions?
Second to both.
Second by Mr. Wynn. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you. Item K, Dina Dent.
Thank you. A second would be to consider approval for product pricing agreement between Stryker. This is for our purchase of 84 stretchers. It'll replace our current outdated and broken equipment. This is for the entire JPS enterprise, not just from a nursing perspective. It'll support all of our departments and divisions and all our patients. Thank you.
Okay.
Any questions for Dina?
This is Dorothy. Move approval. I don't want her to think that we're going to approve all of her getting updated on all this stuff.
Second.
We have a motion and a second. All in favor of the motion, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously. Snuck through again, Dina. Item L.
Miss Dorothy, I was thinking I was getting a rookie pass. I have one more. I'm asking the board to consider approval for exception to bid and approval of equipment purchase agreement between Baxter. Baxter is our sole provider for our CRRT machines, and CRRT is continuous renal therapy. And we really have highlighted that modality and procedure in respect to our COVID population. We have increased by about 20 to 25%. One thing of the impact and outcome of COVID, it directly impacts our organs and primarily our kidneys. Baxter is the sole provider of the supplies needed to utilize our CRRT machines. So our VASCAFs, our central lines, our fluids, and our tubing are all Baxter products. So I'm asking to consider the approval of exception to bid and approval of the equipment purchase agreement for CRRT.
Okay. You've heard the request. Any questions for Dina?
Mr. Chairman, I move for approval.
And that's a two-part motion, Mr. Powell?
It is.
Okay, second both parts. Okay.
We have a motion and a second. All in favor of the motion, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously. Thank you, Ms. Dent. Appreciate that.
Dina, I know on behalf of the board, I hope you appreciate your 17-minute honeymoon, because that it's now over. So congratulations, and we'll move on.
Next couple items are more trinkets for Mr. Mendenhall. David, are you on the line?
I am, and speaking of someone who's had a really long honeymoon, I just assume the board is saving up all the hostilities for me, so I appreciate that.
We're here for you, man. We're here for you.
I know you are. Thank you for that. So the first presentation I have for you is for our services between JPS and Imagine Technologies. We did an RFP for print services for our organization. We've done this RFP multiple times in my tenure here, and Imagine Technologies came up at the very top of our list this time to be able to perform those services for us moving forward, and we're very happy about doing business with them. This is a reduction in our costs that we currently have right now, so we're excited about that as far as our monthly costs. Also, secondarily to that, this is an at-risk contract to where we only have to pay per page that comes out of our printers. So over the last few months, where some of our community health centers have been closed, our cost for printer services has went down, but our services to these printers has remained the same through Imagine. So we're very happy about that. And lastly, I will say is the diversity information that you guys have in your packet has changed. And this was information that William Johnson, who is the manager of diversity, gave us just literally this week, and we didn't want to we wanted to just have a conversation with the board, but where we usually sent out that this is in good faith, and they gave us our diversity information. Imagine actually went a step further, and they have now outsourced 40% of this contract, and we have the documentation to support that, to minority businesses that are in Tarrant County. Part of it is they have decided to outsource their financial services to a minority-owned company. They have decided to outsource their courier services to a minority-owned company. They've also decided to outsource all of the toner, the HP toner that we use to a minority-owned company as well. And that when they saw our commitment to diversity, they wanted to step up and do that and Imagine. So we're very excited about that as well.
Wow, that's great.
That's good. That's very good. Any questions for David? All right. Hearing none, entertain a motion on item M. Motion by Mr. Nguyen.
This is Dorothy. I'll second it.
Second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, David. Let's move to item N.
Right. So, as you know, we've used SunGuard availability systems over the last 10 years for our primary data center services. We did an RFP about 5 years ago to ensure that we were making those right decisions with SunGuard. We now operate 3 different data centers, one here at the JPS hospital that we have been moving things out of on an annual basis, as well as another one through GTS services, as well as SunGuard. This is one of the contracts that I do have to apologize for, that we did push, as Robert talked about that, good bid, right? We got a really good bid from SunGuard to renew these services, and it's a bid of about between $6,000 and $8,000 a month that we're going to be saving for the entirety of this contract for the next 39 months. So we are seeking approval for the arrangement of this. This particular agreement, there is a structural change to this agreement that we wanted to bring to everybody's attention. It's not the same agreement we've done in the past. In the past, we had done agreements that were for IT services at SunGuard. We are changing the structure of that agreement to be a space agreement. So we're just leasing a cage from them and striking out a lot of the other services that they could offer at cost. So we're going to be moving to a new structure with this deal. So that's what we're seeking for your approval today.
Okay. And the exception to bid is based on what? Could you clarify?
Actually, I'll let Mr. Walker talk about that.
Yeah, can I jump in? So
yes, ma'am.
Just to clear up the record, we no longer need the approval on the exception to bid. This is simply a space lease, so it won't require that. The only approval we're seeking is for the renewal of the arrangement between SunGuard and JPS for the lease of the cage.
Okay. Thank you for that clarification. So we just need a one-part motion on this.
More like co-location type thing.
Yes, this is a co-location type thing, right? So SunGuard is actually our primary data center. So we have, from a co-location perspective, we have Epic and other things running out of that data center. Lawson, all of our CRM, all of our ERP systems are ran out of that data center and replicated to our other 2 data centers. And if we ever have a down situation, we could take that service down and bring up our other data centers as needed for our live production. In addition to that, it says in the description, this particular data center is a tier 4 data center, which from a data center perspective, that is the highest level you can get from a designation perspective. I will also tell you that SunGuard has been a huge partner of JPS without service interruption, but more than that, during the COVID timelines in March, they were the first company that actually came to us and donated N95 masks to the organization. And that shows their commitment to us as our commitment to them.
Thank you.
This is
We have a motion by Mr. Zimmerman. Do I hear a second?
Second.
Second by Mr. Nguyen. All in favor of the motion, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously. Thank you, Mr. Mendenhall.
Mr. Mini Chair, I noticed that Trent Petty just joined the board meeting. Do you want to go back to item 1 and do a review of the meeting for Mr. Petty?
That's not necessary. That's not necessary. I completely trust my fellow board member.
We'll go back to the invocation and then we'll.
Yeah. The invocation, maybe I could do some help with, but beyond that, I trust you.
Trent, thanks. I know that you had a really difficult schedule today, and we're appreciative. Thanks a bunch.
Marathon lawyers. All of you who are lawyers, I love you, and I pray for a long life for all of you.
Mr. Skillens, item O.
See, I got the mute button that time, Robert. So I know he always gets me on that. So
proud of you.
So item O is a policy LD 5300 reimbursement practices. This is a policy that is coming up for approval mainly because it's been passed over a 3-year period of time. It basically clarifies compliance's role in general oversight of billing compliance and training matters. And so, as those of you on the governance committee know, we do this mainly through training, billing compliance audits, and coordination with various parties, including finance, case management, and HIM. So the changes here are mainly just for clarification. This was an existing policy. And as reference, procedure 5301 is in the portal for reference.
Any questions for Ron? And I'll defer to the chairman of governance committee. If you have any items issues you want to raise, feel free. Okay. Hearing no questions, entertain a motion.
This is Dorothy. Move approval.
Motion by Mr. Bose.
I'll second it.
I believe that was Dr. Weber that seconded it.
Yes, as it was.
A motion and a second. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, Ron. Item P.
All right, item P is coming back to the board, LD 2900, dealing with leadership. This is a approval to be archived and removed out of the policy database, mainly because it's redundant to organizational charts and bylaw documents that we currently exist. At the last meeting, Dr. Miles wanted us to double check that with our Joint Commission consultant to ensure that our understanding was accurate, and so we did go back and do that and did get that confirmation. So this would be an approval to archive this policy.
Okay, you've heard Ron. Any questions for Ron?
Thank you guys for working through that to get that clarified through Joint Commission.
Absolutely.
Entertain a motion for item P.
Move for approval, Mr. Chairman. Oh, excuse me,
Motion.
Mr. Chairman.
Mr. Mini Chair.
Oh, you MC.
Motion by Mr. Powell. Do I hear a second?
Second.
Second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, Mr. Skillins. Well, Dina, you got through the first time. Here you are again. You made a strategic error here. Item Q.
All right, thank you, Mr. Mini Chair. PC 800 is our moderate sedation policy. The only changes in this policy is our reference update. This is to help us standardize our sedation across our organization.
Okay.
Any questions for Dina?
Move approval.
We have a motion by Mr. Bose. Do I hear a second?
Second by Amanda.
Second by Ms. Arizola. All in favor, please say aye.
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 Opposed? Motion, hearing none, motion passes unanimously. Thank you, Dina. Dina, item R.
Thank you. This is PC 1000, our restraint and seclusion policy. Our updates for this policy are references. Our policy for restraint and seclusion allows us to have established guidelines to actually prevent restraints and seclusions on our patients. Thank you for consideration of renewal of this policy.
Thank you, Dina. Any questions for Ms. Dent?
Move approval.
Motion by Mr. Bose. I hear a second.
Davis Charlie, I'll second.
Second by Mr. Powell. Thank you, Mr. Powell. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, Ms. Dent.
Thank you.
Item S, we're making progress, guys. Ms. Ball, Bama Ball, item S.
Good afternoon, Mr. Mini Chair. I'm here today to present a policy RI 1000, Declaration of Mental Health Treatment. There were really not major changes for this policy. There were some changes in the procedure, but it was just to update for current state Texas law. And I know the procedures are attached for your reference. This policy is actually a federal law requirement as well as a Joint Commission requirement and state of Texas requirement. So this brings us into compliance with all.
Okay, thank you, Zelia. Any questions for Zelia on this one?
Move approval.
Okay. Motion by Mr. Bose. Do I hear a second? I hear a second. Second by Dr. Weber. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Thank you, Ms. Ball.
Thank you.
Ms. Boder, item T.
Yes, and good afternoon, everyone. I'm seeking your approval for policy RI 1800. This is the policy that lets us offer our patients the protection of consent for the recording of their image, likeness, audio, video. Since I started 4.5 years ago, we made it a department practice to extend that protection to their family members, guests, visitors on campus at any time. And with this policy up for renewal, it is time to make that official. So the changes you see include any visitor to JPS campus. And I'm asking for your approval.
Any questions for Diana? Hearing none, I'll entertain a motion on item T.
Move to approve.
This is
By
Dawn.
Ms. Arizola, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously. Thank you, Diana.
Thank you.
All right, item 11, consent agenda. Any items on the consent agenda that a member of the board would like to have removed for consider from the consent agenda? Thank God, no one said yes. So, hearing none, I'll entertain a motion on approval of the consent agenda on item 11.
This is Dorothy. I move for approval of the consent agenda.
Zim, second.
A motion by Mr. Bose, a second by Mr. Zimmerman. All in favor of the motion, please say aye.
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 Opposed? Hearing none, motion passes unanimously. Goodness. All right, report of legal counsel, Ms. Walker. Item 12.
Thank you, Mr. Co-Chair, or mini chair, whichever you prefer.
Jenny chair.
Mini chair.
The only report I have is to report the number of contracts under 500,000 for the month of November, and we had 47 contracts on that list.
Wow.
Wow, okay. Any questions for Daphne on this item? Thank you very much. I don't think that's an approval, right? That's a report.
Okay.
Okay, we do have a couple items in executive session. What would you all think about taking a 3-minute bio break and coming right back and knocking this out? Okay with that?
I'm okay with that.
Good recommendation.
Okay. We will adjourn to reconvene 3 minutes in executive session. Thank you very much. We're board managers will reconvene in open session. We have a couple items for the board's consideration. One is I'd like to recognize Dr. Hurd. Make a motion on privileges.
I propose a motion to approve the privilege as presented in executive session.
Okay, you've heard the motion. Do I hear a second? Second by Mr. Bose. All in favor of the motion, please say aye.
Aye.
Aye. Opposed? Hearing none, motion passes unanimously. Second, I'd like to recognize Mr. Petty.
Yes, sir. I'd like to make a motion to authorize Robert Early to negotiate and execute an option to lease the real estate located at approximately 300 East Magnolia Avenue for the exclusive purpose of enabling Magnolia Lofts Ltd., whose general partner will be controlled by an affiliate of Tarrant County Hospital District or a public facility corporation whose sponsor is Tarrant County Hospital District, to obtain 9% low-income housing tax credits from the Texas Department of Housing and Community Affairs to finance, construct, and operate an approximately 69-unit apartment complex on such property.
Okay, you've heard the motion. Do I hear a second?
Second.
Here on Mr. Wynn. All in favor of the motion, please say aye.
Aye.
Opposed? Hearing none, motion passes unanimously. Thank you, Mr. Petty. All right, no further business. Merry Christmas to everybody. Happy holidays, happy Hanukkah. Be careful, be safe, take care of yourselves and others. Thank you all very much. We are adjourned.
Merry Christmas.